I'm Jane, County Enterprise Foods Team Manager. We were established in 1987 and the reason behind it was to make meals for our own Meals on Wheels service, but also to provide employment for people who would find it difficult to find work mainstream. So that is people with either a learning or a physical disability. We give them independence and we promote their well-being. We work alongside them, supporting them in the workplace, but also holistically. It isn't just coming to work and being a number. And they are very, very proud of the job that they do and how well they do it, and rightly so. They have won awards for the work that they do, and you know, it builds their confidence to feel valued.
I'm Jane and I work at County Enterprise Foods, and I've worked here for 29 years and I really enjoy it. I used to be a very shy person. I've grown a lot of confidence while I've been working here.
When you walk through the door, no visitor goes away without saying how nice the feel is here, because it's a very different kind of workplace to work where you are continually supporting staff as well as doing your job. The other part of our work is to provide a nutritious, well-balanced meal. We produce over 2,000 meals a day, and our team take great pride in everything that they do to get the best product.
The health and well-being of the customers is really important. We use locally sourced ingredients when we can, so we keep everything fresh. We've got 90% of the fresh vegetables here as well. In combination with the fresh cooked meats, we have a good nutritional balance to the meals, which is essential.
The food that we have can be traced back to the farm, so it very much is a farm to fork process. After the production of the meals, they come down to our distribution unit here at Rainworth, and we have 19 vehicles go out every day to deliver throughout the whole of the county. We have a freezer route, but the majority go out hot in our vehicles with the oven in the back of the van. The service we provide is essentially the good, nutritious meal that people get, and as well as the customer getting a hot meal or a frozen meal, whichever is their choice, we have safe and well checks, and this is part of our way of helping people remain independent.
Hello.
Hello.
Hi Gwen, I've bought you dinner.
Right, okay, Doc.
Here we are,
Thank
Ducky.
you.
How are you today? It's good for the families. It gives the families peace of mind. We're turning up on a daily basis and checking on the relatives and making sure that they're fine. And with us knowing the clients as well as we do, with us coming every day, we can normally tell if something's wrong straight away.
I'm Gwendoline and I'm 91 years of age and I don't feel it. My favourite dinner's beef and Yorkshire pudding. The meals help me to keep my independence. It's more than just a meal.
It's not a normal run-of-the-mill job. When you've done at the end of the day, you go home and you know that you've achieved something and you've helped people, and you get that every single day.
Notts County Council have always been very, very supportive of what we do. It is down to them that we are still here and that we still have this work ethic, and it enables us to continue.
I'm Gemma and this is my husband Paul, and we're both foster carers. I think initially we were a little bit anxious ourselves about going to panel, It sounded quite scary, but it wasn't at all. It was just a really friendly chit-chat with a group of people around a table. It was more of a celebration, really, of us being there and of us, wanting to become foster carers. The County Council offer a fair rate of pay, so we get paid dependent on our level of experience. So after you've done it for a while, then your level of pay will go up based on your experience and level of training that you've done. We've also got a network hub, which is a foster carer support group, and it's just an informal get-together. We feel so valued as a foster carer for Nottinghamshire County Council. Everyone's so caring and wants what's best for you as a family. The matching process is really careful, so they listen to our needs and, they would never think of placing a child that wouldn't fit in our environment. As a foster family, we try and just make it everyday, normal life, try and bring some stability and love to that child that's staying with us and give them experiences that perhaps they've not experienced before. We love going out on day trips together, and for example today we've come pony trekking. Nottinghamshire's a great place to foster because we've got so much on our doorstep, there's so much that we can do. I feel really lucky that we're able to foster here.
There is no doubt that without the support from Shared Lives carers, Joe's family would probably have ended up in crisis. But with the support of Julie and Yvette, the family do not have to cope alone, and they now enjoy quality time with Joe on a regular basis.
Helen and Mike's care has been fundamental to Daniel's development, safety and happiness, and my peace of mind. They have been sensitive to Daniel's challenges and needs, as well as myself and my family. I am now widowed, and their support is utterly essential to me and my other son in making sure Daniel's needs are met. I'm continually in awe and appreciation of the work they do for my son.
Chantal loves visiting Hayley. She says it's fun and exciting. She gets to spend time with someone her own age. Hayley's such a lovely friend to Chantal. The family now have time to go out for meals, walk the dog and just chill.
Family members closest to Sarah have been able to gain great comfort and relief from the fact that Sarah has found a new family where she is happy and enjoying life to the full. The support that Sarah has received from Kelly and Ross have given her own family the time and space for them to better cope and manage through the difficult times.
Gemma's support means everything to Sophie and I. Sophie loves staying at Gemma's and does a lot of different things when she's there, and she's very helpful too. For me, I have more me time, and we would definitely be lost without the support we get from Gemma.
I'm Gemma and I'm a shared lives carer. Started off being a foster carer for Sophie and then she turned 18. So I became approved as a shared lives carer so that I could continue caring for her. We take shared lives as a whole family commitment, and my husband Paul and my children Millie and Toby all see Sophie as part of the family. Sometimes we don't do anything special, we just do everyday normal family things. Millie had weekly horse riding lessons and Sophie used to come along and watch her ride, and she wanted to have a go as well. So I spoke to my shared lives coordinator Jackie, and Jackie gave us the go ahead to try.
I'd like to welcome you all to this meeting of the committee, which is being held remotely, with the majority of 11 members join the meeting from their homes. As well as myself, the other members present in this meeting are today Councillor Martin Wright, who's the Vice Chairman, Councillor Richard Butler, Councillor John Doddy, Councillor Kevin Greaves, Councillor David Martin, Councillor Liz Plant, Councillor Kevin Rostance, Councillor Stuart Wallace and Councillor Muriel Wise, and Councillor Yvonne Woodhead. Health Watch Nottingham and Nottinghamshire is represented today, today's committee meeting by Ajanta Biswas. We will be joined today by a number of NHS representatives to inform us our discussions. These are Hazel Buchanan, Assistant Head of Special Projects. So John's not coming, isn't it? Lewis Etoria, Head of Insight of Engagement. Lucy Dadge, Chief Commissioning Officer. Mark Simmons, Divisional Director of Medicine NUH. Nina Ennis, Associate Director of Joint Commissioning and Planned Care. We also have the following officers present: Martin Gately, Health Scrutiny Lead, who's at home, and Noel McMenamin, Clerk for the committee, who's at County Hall. This is the first virtual meeting of Health Scrutiny Committee to be held in line with the new requirements of the Coronavirus Act 2020. Please do bear with us if we experience any technical issues. If we do lose any members from the call temporarily, then Office will seek to assist in getting them reconnected as soon as possible, hopefully without the need to halt proceedings. Officers will inform the meeting if they are unable to rectify the problem and if we need the meeting to be paused or adjourned temporarily. During the discussions, I would ask that members refer to agenda packs page numbers when referring to points within the committee papers. Okay, we're all happy with that. Okay, so item 1, to note the appointment by full council on the 11th of June 2020 of Councillor Keith Girling as Chairman and Councillor Martin Wright as Vice Chairman of the committee for 2020-2021. To ask the committee to note the appointment, there will be no vote for that.
Noted.
Thank you. Item 2, to note the membership of the committee for 2020-2021 municipal year as follows: Councillors Butler, Dr. Doddy, Greaves, Martin, Plant, Kevin. Oh, Kevin Rostance gets his first name as well. Wallace, Wise, and Woodhead. Threw me a bit, that did. Okay, and again, that's to be noted. No formal vote. Minutes of the last meeting held on 25th of February 2020. To ask the committee if the meetings can be agreed. If anybody doesn't agree, speak, please. Liz? Yeah, Liz. Take yourself off mute, Liz. Liz, take yourself off mute.
Helps, doesn't it? Okay.
That's it.
Right. I wanted to raise a point on the minutes. Is this the wrong opportunity?
No, this is the right opportunity.
Okay. So it's page 6 of, yes, and it's the, we were going to have, in view of the paucity of information provided in advance, this is about the Nottinghamshire Healthcare Trust. They were supposed to be coming to the main meeting, with more, because we didn't have very much information last time round. I'm just wondering what's happened to that.
Martin, can you advise us on that, please? Martin Gately.
Thank you, Chairman. When obviously the programme of meetings is disrupted, and so obviously we didn't have a main meeting for them to attend. And I don't recall receiving any further information from Council Plant, and obviously I will chase that up now that you've reminded me.
You happy with that, Liz? Thumbs up. Yeah, excellent. Thank you. Apologies for absence. We've just got the two NHS staff. Is that right?
Yes. Oh, apologies for my being off site. Yeah, no apologies other than our two external representatives who aren't with us today.
Okay. Item 5, declaration of interests. Do any members or officers present have any disclosable pecuniary interests or to declare? Do any members or officers present even have any private interests, pecuniary or non-pecuniary, to declare? Please speak up if so. No. Okay, I take that as none then. Okay, item 6, National Rehabilitation Centre final consultation document. Introduced. The report committee has been involved in shaping plans for the NRC over several years. I welcome Hazel Buchanan and Lewis Itoria. Take the floor.
Morning. Thank you. It's good to see you all again. So we've been presenting the Regional Rehab Centre to you for formally for a year now. And during that time, we've gone through the business case and the proposals, and I'll recap on some of the main elements of the proposal in a moment, and also been talking to you about the pre-consultation engagement, which we've carried out through focus groups and surveys. And then today we're here to talk to you about the consultation plan and taking forward the consultation through virtual methods in the situation that we're in. So over the past year, what we've also brought to you has aligned with the NHS England process. So as you can imagine, for a proposal such as this, there's a robust process through NHS England and different stages, and we've just recently passed the assurance stage that we need to get it to the point of going out to consultation. Lewis is going to talk to you more about the consultation plan, and I'm just going to recap on the project itself. So we're talking about the Stanford Hall rehab estate. This is a purpose-built estate which includes a military facility that opened in 2018. This is a real state-of-the-art facility with facilities that will be available for the NHS to access, as there will be an NHS building on the same site. I think it's important to note that the two buildings are separate and will be managed as two separate sites. And we would have, as mentioned, access to these facilities. The NHS has had this opportunity due to a donation of land from the Black Stork charity who own the whole estate. And we have received planning permission for the rehab facility, and there has been capital funding allocated already to this proposal. So it's a really exciting opportunity, and as part of this, we've been developing the clinical model. The clinical model includes neurological patients and MSKs, musculoskeletal patients, and that particularly includes complex fractures. So those are the two main groups that will be treated at the facility. It does include the opportunity to have a research and training facility, and that is being taken forward separately. So we are specifically talking about the NHS facility itself, but the it does lend itself to greater opportunity for the research and the training side as well. So just to mention, as part of the clinical model, the proposal includes transferring Linden Lodge from City Hospital to the National Rehab Centre. And this is because of the facilities at the city and that it's not possible to maintain those for much longer, and of course the opportunity to move Linden Lodge to state-of-the-art facilities. So over the past year, so I thought I'd just highlight some of the things that you've raised and that are considered through the consultation and also are part of developing the clinical model. So a particular area highlighted has been the travel concerns and the location and the accessibility. And we've highlighted a number of mitigating actions around that and are exploring this further through the consultation. There's the proximity to the military side and assurance that the military and civilian side would be separate. And we've confirmed that they wouldn't be on a day-to-day basis joined together. And as mentioned, it's accessing the facilities, but it would be NHS staff who would be looking after the patients in the military facilities. There's of course Linden Lodge and ensuring that services that are currently provided in Linden Lodge are maintained, but then also that the staff are transferred over, and you've highlighted how good the staff are at Linden Lodge, and we want to maintain that level of service. There's also discussions around the post-discharge and the availability of services to maintain the patient care and to ensure that the benefits of the enhanced rehab is maintained once they are discharged. But in particular, you've asked for assurance that we were linking in with social services and that they were part of the clinical model. And we continue to work on the discharge planning, but absolutely social services is part of this. And I think really you highlighted that this is a great opportunity, and if we do get it right, it is a significant benefit for Nottinghamshire and the wider region. So I'll just hand over to Lewis now, who's going to talk to you more about the consultation itself.
Thank you. I won't run through the consultation plan line by line. We shared the consultation document and the consultation plan. So what I'll do, I'll just give you the highlights of how we changed the approach to take account of the current situation. So essentially, the consultation plan still has the same objectives, the same principles. We're still consulting on the same single option. The difference is we've taken out the face-to-face activity and put virtual online engagement activity in its place. A few months ago, we took legal advice from the CCG solicitors and also advice from the Consultation Institute. The consensus of the advice we've received is that taking the face-to-face engagement out of the exercise doesn't weaken it. So we still can run a legal and best practice consultation as long as we put certain mitigations in place. So the mitigations that we have in the plan that you can see are the consultation period has been extended. So we were planning a 6 weeks consultation. That's now been extended to 8 weeks. The virtual events that we're proposing to run will run on the same kind of format we would run a face-to-face event. So there'll be a presentation and a Q&A, opportunity for discussion. We'll run those, one in the morning, one in the afternoon and one in the evening on different days to work around people's commitments, shift patterns and things like that. We've put some extra resources in to promote the consultation. So we've commissioned a video, animation, some other visual resources without having to face the face-to-face engagement in there. They'll help describe the proposal and bring it to life. We've also put extra resource into advertising the consultation. So we're quite keen to draw up the numbers of survey responses as we don't have face-to-face engagement. So We'll buy some paid for press advertising. We have press advertising in neighbouring areas, press advertising on Facebook advertising as well. We've set up a free post address for hard copies of the survey to come back to, and we've also now set up a phone line for people to request survey completion over the phone or just to give feedback over the phone. If you recall, we also had Healthwatch on board as a delivery partner. So the impact assessments recommended that we do target engagement with a number of groups who might face barriers to accessing the service. So that will still go ahead, but that will go ahead by phone methods. So our proposal is to run the consultation, to run it with non-contact methods, but with the mitigations we've described. The consultation period will be 27th of July to the 18th of September. So purpose of today's visit is to bring you up to speed on that, share the proposal, get your feedback on the mitigations, and we also want to take the opportunity to formally notify the committee of our intention to consult on that date. So we'll pause for questions at that point.
Okay, thank you very much. I'm really excited about this because I think the opportunities that it brings for learning from the military side in terms of what they do and the cross section in terms of that will be amazing. I think a lot of people will benefit from that. I'm going to open it up to the floor. Who's got any questions? I can't see any hands up, so who's put a hand up? Liz, we'll go Liz first. You go first. Liz, take yourself off mute. Yeah, I've got Stuart.
Yeah. Okay, thank you, Chair. Yeah, I suppose similar to all consultations, I have to say this seems a very, very comprehensive one, without a doubt. So I'm just wondering, to what extent will the consultation responses be able to shape or influence the proposals at the end? Thank you. On mute.
No, I think you muted yourself.
So yeah, thank you. There are a series of workshops set up to consider the findings of the consultation. So I think we have 3 set up. So that'll bring clinicians together with some patient representatives to go through the results of the consultation and inform the final decision-making business case. So the business case that you would have seen to date is the pre-consultation business case. The final proposal that will go to NHS England will be the decision-making business case. So we've built in plenty of time between the close of the consultation and the creation of that document to do that.
Are you happy with that, Liz, or do you want to come back? Unmute if you're coming back. Okay, thank you. Stuart Wallace.
Thank you. Can you hear me? Yeah.
Yep.
Okay. Obliged to you. And thank you for the presentations from both of you. Some of the concerns I've had and I've had throughout is, while this is an exciting development, and I fully support that part of development, I've always been concerned by sticking it out in the countryside. You actually, in fact, make it very difficult for relatives or other people who can get to it. But that's where it's been decided to put it, and I understand if somebody offered me X number of acres free, I would go for it as well. So I understand that. When I look through the consultation process and how you were going to deal with what you call isolation, and you quite rightly identify that the people that will be using it from the NHS side are going to be a mixed group of from younger people right through to elderly people, where the military one, of course, is, apart from people having been obviously damaged, is young fighting men and women, etc., where the population that we're going to be putting is right across the thing. So travel and getting to it, and the necessity to go more than once, all you have in there is a statement that says, examine through the consultation process transport. I don't understand what that sentence means. The centre is going to be built there. The nearest city is either Loughborough or Nottingham. So what in actual fact do you expect to come from that consultation, and what changes would you be looking to make to allow people to be able to get towards it? My second area, which follows on, is that looking at the number of beds that you have, 40 odd beds, and I understand that you're closing down other units in order to supply that, how quickly will the centre be full, and will we have yet a waiting list yet again? And my final question is, when I've looked at the finances that you've got on your sheet, you don't seem to have any development for costs running forward. In actual fact, your costs remain static and go down. Now, I can appreciate the fact that the monies that were put into the oldest units that's going to be taken out of circulation will be able to be used. But what happens in year 3, year 4, year 5? I would have thought you would need a constantly built into your budget increases for a very technical but expensive area.
Thank you. I'll just take the one on transport and then hand over to Hazel to do the question on the beds and the finance as well. So the reason that we've got transport as a discussion point for the consultation is it came up as one of the top issues when we did the pre-consultation engagement in both rounds. And it came up as a mixed issue. So some people concerned about public transport to the site, but other people quite supportive of being able to visit relatives somewhere with car parking. So particularly people who've been to City Hospital or Queen's and struggle to park. So it's just an opportunity to explore further if the mitigations around transport people feel will be enough. So currently, and Hazel can add to this, my understanding is that there's a regular bus service to the site, and there are ongoing discussions between various bits of the NHS and voluntary sector transport providers as well. And I'll just bring in Hazel there to add to that and to take the second two questions as well.
Yeah, I think, I mean, as you say, it is a challenging area because everyone recognises that there will be concerns over travel, and as Lewis said, it's just how best do we mitigate that, and that's where the consultation is really just to get some further it's a further understanding of how difficult this will be for individuals, and it's recognizing the importance also of visitors to the recovery of individuals. So I think it's really through the consultation, it's how do we explore it further as an area of concern. On the on the beds, so it's actually 64 beds. As you say, is 64 the right number? This is going to be a regional centre, so there is the concern that's been raised by our governing body as to is 64 enough? What this is a iterative process, so what we're working through at the moment is the data modelling and trying to really more fully understand the unmet need, which is part of the decision-making business case process. So we are working with our neighbouring CCGs and with the trusts to really understand, as I said, that unmet need and how does that impact on the case mix of the neurological and MSK patients. So your question around a waiting list, well, we're obviously we'll be working to there not being a significant waiting list. There still will be the units in King's Lodge, and there still will be the access to be rehabbed through other sources for the neurological side, but it is something that we're working through in more detail for the decision-making business case. So you will see more information when we bring this back to you around that. But it's definitely something that's on the forefront of our minds and the work that's happening for the decision-making business case. And then just on the budget is for the pre-consultation business case. So the budget's being based on what we know now, and as we go through the different business cases, it will become more detailed. This is just double checking or just confirming the affordability at this stage, but there is quite a bit more detail to work through. So that budget will continue to develop as we go through the different, as I mentioned, the different business case stages. After the decision-making business case, there is also more work that's done in relation to the capital business cases as well. So it's quite a complex process.
Are you happy with that, Stuart, or do you want to come back?
Well, thank you for that. It's a complex question I asked you, and it's a complex answer I've had back. Let me pick up and let me concentrate on one little item, and that goes back to the one of transport. When you read your documentation quite rightly identifies that a number of people using the centre will come from poorer areas, will not necessarily have transport themselves, or not have people that they can rely upon to transport them in. And there's an understanding almost that the people can get into Nottingham Centre to catch this bus, or if there's one coming from Loughborough, etc., to get in. I think it is the Achilles heel. They say that the people coming from the armed forces are younger and will have a lot of more support than will people that are coming in from the rest of the area. And I think it's an issue. If you want to stop isolation, you have to allow people to have people come and see them, etc., while they're in there, or whatever, or people who are having to come in for 3 sessions, 3 consecutive times to come in, need that transport. And I think that still needs to be clarified in the consultation. But otherwise, I'm finished. Thank you, Keith.
Thank you, Stuart. Hazel?
Yeah, it is. It definitely is, it will be, as Lewis mentioned, it definitely will be explored further in the consultation. And I do wonder whether through COVID, actually, there's we'll learn more, because there's been so much virtual communication, but then also around the shielded patients and isolation, and what does that mean? And so this may actually provide us with insight through the consultation that we hadn't have thought of before COVID, and how best can we manage it. But what I can say is that the programme is absolutely keen to do what they can to help, and recognising the importance of visitors and recognising the importance of regular contact. And it's really that insight into what can we do, as opposed to we're not willing to do anything. It's more what else can we do?
Okay, thank you. I'll just explain, because I know I explained it to committee, but there'll be times when my screen goes off because I've got to stand up and walk around because of my operation's not even four weeks old yet, an operation on my back. So I do apologise to anybody watching in, but I just have to do it. Just so you all know, I've got Councillor Doddy next, then Muriel, then Martin, and then Agenta, and then Yvonne. So that's who I've got in the list at the moment. If you want to speak and you're not on that list, okay, Councillor Martin. Right, okay then, so it's Councillor Doddy, please.
Yeah, thanks very much indeed. I think we're used to listening to this over quite a period of time now, and looking at what should be, a source of great pride to us in the East Midlands and nationally in due course. Who knows, we may even see some of the complex recovery cases from COVID appearing down there for rehabilitation for people on ventilators for months and months and months. So you don't know what it'll be used for potentially in due course. When I look at the budget, following on from the previous question, we had something like 23 beds or something that we were going to transfer across, and we're now getting something in excess of 60 beds. So we're getting 3 times the facility, 3 times the amount of capacity for the existing budget. the existing budget, somewhere between 11 and 12 million over year 1 to year 5, is apparently going to triple our capacity for complex neurological rehabilitation. Is that, in actual fact, the reality of the situation? Are we getting 3 times the capacity for the same budget we've had? If it is the case, then I think it sounds to me like a remarkably good deal. If it's not the case, is there any provision for changes, or are we being subsidised in some way by the military? I wonder if you could give me some clarification over that.
So, no, we're not being subsidised by the military. And as mentioned, we've had the land donated, but not being subsidised, and there's no funding from the centre. But it's important to note that it's neurological and musculoskeletal patients. So, and the MSK is the complex fractures. So there is the 21 beds that will transfer over from Linden Lodge. We've got 40 beds that are neurological in total and 24 that are MSK. As mentioned, there's the unmet need, and so what there will also be, or what's included in the business case, is the transfer of patients from the acute facility into the rehab centre, and so it's how are we impacting on length of stay and the costs in acute care, and transferring those costs over to the rehab side. There's also an element in there around continuing healthcare, and at the moment that's quite a small element that we've included in the savings or the transfer of funding, and we're exploring that further, in particular for Leicestershire. And so it's how, if we're providing intensive rehab, and we're providing rehab to people that aren't currently able to access rehab, then how will this impact on things like continuing healthcare as well? So that's where we're able to balance the business case, or the budget, so to speak, and there'll be quite a bit more work going on around that for the decision-making business case, and as I said, the subsequent business cases, as we develop the clinical model further, and also understanding the impact on the other areas. So this is where it's really important to recognise that this is the pre-consultation business case is at an early stage, and we've had to do quite a bit of work with NHS England on the numbers and also closing the gap. So we did have a significant gap when we started on the pre-consultation business case, and have worked that through further, and that's looking at the different patient cohorts. But it's by no means complete yet, and there is quite a bit more work to be done, but it's complete enough to inform the case at this stage.
Thanks, Hazel. It just is a small paragraph, and I'm sure elucidation will come in the fullness of time. It's just a case of whether we are actually achieving more for our money in a state-of-the-art facility, and it's not immediately obvious where our increased capacity is going to come from. Is it an increased capacity at all, or just a movement of care into another surrounding? Because we were all sort of getting the impression we've got all these extra beds, whereas in reality what you're saying is that the budget isn't just Linden budget, it isn't just the closure of that budget, but it's all the other budgets associated with the musculoskeletal and other treatment that exists around the East Midlands that are combining to give us the £12 million budget, which is going towards the care at the rehabilitation centre. But I've no doubt that, as you say rightly, we'll get further clarification on this as we move along, and may not be quite so important at this stage of consultation, and we may get that in the fullness of time, and I'm very happy with that. Thank you.
I don't think there's anything to come back on there, Hazel, was there?
Okay, thank you.
Okay, lovely. I've got Muriel next then, please.
Thank you, Chair. Thank you for the presentation, Hazel. It is very exciting. My question is really about resources. So, I'm visiting the unit at the city. The equipment there did look very sophisticated. Now I understand that's moved to the Queen's, and I just wonder, firstly, has equipment been moved to the Queen's as well, and will that unit remain at the Queen's? And I suppose following on from that, what would be the criteria for deciding whether someone goes to the City Queen's resource or goes to the rehab centre? Thank you.
Sorry, Muriel, which unit are you referring to at QMC? The stroke unit?
Muriel, you have to take yourself off mute. Muriel, take yourself off mute.
Yeah, thank you. But the stroke unit at the city, and I understand that is now the stroke unit at the Queen's. And so what would be the balance between people going there? So will the local centre for stroke work remain?
Yeah. So the stroke work in the stroke pathway is being seen as separate, but obviously if someone has complex needs that may be met by the rehab centre, they may go to the rehab centre. But the stroke unit as it is will remain at QMC, and no equipment will transfer from there. There will be all new equipment, and there's 3 gyms, I believe, in the rehab centre, and other facilities actually in the NHS building itself. So the NHS site will have all the facilities and equipment that it needs, and it won't be transferring from any other units such as the stroke unit. As for the criteria, it will be, so they're quite high level at the moment, the referral criteria, and it's someone having rehab need and rehab potential, and they're a neuro patient that's fit for 2B rehabilitation, and then the MSK is complex fractures. We have also said severely deconditioned patients may access it, and traumatic amputees, they're smaller in number. So it's a balance of keeping the referral criteria loose enough so you're not wholly restricting it to people that would really benefit, but then not so loose that you can't, that it's then seen to be open to anyone. And so as we develop the business case, the referral criteria will be part of that, and the clinical model. But at the moment, it's rehab need and rehab potential. And Emma, those groups that I mentioned, there's going to be a triaging process and referral hub, so to speak, so that then the referrals will be reviewed by a multidisciplinary team, and to establish the rehab need, and that's where they will see the patients. From my understanding is they'll see the patients beforehand and really understand that rehab need and rehab potential. And from our perspective, we're keen that, obviously all those patients that currently access Linden Lodge are still accessing rehabilitation at the regional rehab centre.
Thank
Are
you.
you happy with that, Muriel?
Yeah,
Or would you want to come
thank
back?
you. No, that's fine. Thank you.
Lovely. We've got Martin Wright then, please.
Thank you, Chairman. Thank you, Chairman. I've just got a couple of points to make. One is one we've heard of quite a lot this morning, and backing up what Councillor Wallace says, that transport arrangement is the Achilles heel of a wonderful facility. I just wonder what can be done. I mean, I'm a councillor for Mansfield. In the room, so to speak, today we have councillors from Ashfield, councillors from Worksop. Extensive travelling would be required to enable these visitors to visit any relations or etc. or friends in the new rehabilitation centre. The travel impact assessment acknowledges the fact that public transport journey time would rise from 60 minutes to 126 minutes. That's a long time on a bus, and it's a long time for elderly people to try and get there. And then question 6 on the consultation document, which refers to the travelling to and from, and whether you would like the facilities that are going to be provided, only mentions public transport once. Discussions are taking place around enhancing local public transport, which, okay, we all know what that means, but it doesn't help people to really answer the question. So that is one point I'd like to make, and I know Hazel has done her best to answer it already, but I had to ask this question on behalf of my residents and residents in the north of Nottinghamshire. My second point, and disappointingly, I thought from the onset, and Hazel will obviously correct me, well, she has corrected me, but I thought from the onset that training and research was going to be included in the new NRC. And I was quite excited, and I believe at past meetings we've had a conversation about how staff transferring from Linden Lodge would go to the new NRC, improve their skills, and then probably even move on to other NRCs that may or may not be built in the future. So that's the 2 points I've got. One on the training, and one, again, I'm sorry to say, on the availability of public transport and what could possibly be done to help it. Thank you.
Before you answer, Hazel, I'm under that impression about the training. You know, we heard about artificial intelligence, we heard about training, we heard about that's why I was quite excited about it, the learnings between, because, you know, the military will be the absolute pinnacle of advancement in terms of dealing with trauma. Because they get lots of people to work on effectively. So I'm quite surprised about that.
So you can still be excited about it because it's still there. I think what it's really we are managing the NHS process, which is around the rehab centre itself, the NH Rehab Centre. The research and education bit is funded totally separately, but is still part of the overall program. So we're not, in fact, we're not commissioning, or we're not doing a business case for the research and education bit. They're working with they're looking at having a consortium which includes the universities that will be funding that. So that is all still going ahead, but it's just not part of this business case. So it's absolutely still part of it, and it will ultimately be one building. But we have had the funding for the NHS facility. So yeah, so rest assured that's all still there, but we will be talking to you about the NHS facility. But yeah, that's still there, and part of the ongoing work and looking at the workforce plan as an example is around how do we get people trained and inducted. Well, that will be part of that education centre and the plans that they're doing around that. So you will later down further on, when they've got the funding all approved for that side, I think you'll probably see it more presented as the single opportunity. So it's fully there. As for the travel, yeah, we've mentioned it. Is it, Councillor Wallace, I wasn't sure whether you were saying you think the consultation document should change, or that there's some more ideas that potentially we could put forward, or you might have, because we're absolutely open to other ideas. So one thing that's being discussed is the charity and charitable funds, and how do we set that up so that we can support people with travel costs, and that's on on top of the other mitigating actions. But if it's around the consultation plan and the questions that we ask, then absolutely that's feedback that we need today, and Lewis can take away for the plan.
Can I?
Oh, sorry, Councillor Wright.
Yeah, go on, Martin.
The question I was asking, or the point I was making about question 6 on the actual consultation document, it goes in to tell us that to reduce the impact to relatives, friends and carers, it is proposed that the NHS Rehabilitation Centre would provide some family accommodation, which is good, free parking, which is excellent, as well as super fast broadband to enable patients to keep in touch with families, which is good. Then at the very last half a sentence, well, it's a full sentence, but half a page, discussions are taking place around enhancing local public transport. It doesn't give anybody who's filling in the consultation an opportunity to select what they'd like to do. Would they like a bus direct from Nottingham? Would they like a bus direct from Loughborough? It's just an open question, and I just can't see how that question can really help you formulate an answer to that awful question. Thank you.
Lewis, do you want to comment on that?
Yeah, I mean, it's a fair challenge. It would be quite difficult to structure a question on transport in a way that takes account of all those options. So that's the reason for leaving it open. What we can do, and we would have done in the plan, was make the discussion on transport front and centre of the events and focus groups. It came up in the engagement. We expect it to come in the consultation. So it will be a central discussion point. And what we can make sure we do with the questionnaire is have a real focus on anything that refers to transport when we look at the data as well.
You happy, Martin? Brilliant. Okay, I've got Ajanta next.
Thank you, Chair. So I have a follow-up question to a previous councillor who has raised on how the findings of the consultation will be implemented. And I am aware that Lewis has already answered this in part, but that raised more questions for me, I'm afraid. So Lewis, you said that there'll be a workshop for implementation of the findings of the consultation. And in this document, you do talk in the phase 3, phase 4 of having findings a consideration panel. However, my concern is this, that Health Watch will be consulting with groups of population which are seldom heard, such as homeless, people living in poverty and long-term unemployed. And my fear is that there is a danger that these findings from seldom heard groups are actually lost by the time it goes into the consultation outcome document and processing all the data and all of that. So I believe that there should be at this stage 2 things. One is a very clear pathway on how the findings of this consultation, which has taken so long, and there has been so much thought put into the process on actual consultation, but it appears that very little thought has been put into what we are going to do with the findings of the consultation. So rather than charting that pathway, once we have the findings, I believe that it would serve the consultation better if there is clear pathway on how the findings of the consultation will be taken on board so that they don't get lost in the various triage of processes. And my second point on the same topic would be that these workshops that you're talking about, it feels that it should be mandatory that the groups that are consulted, they have representative of those groups. And I think I'm answering my own comment that it will be very difficult to have that. And I fully appreciate that. But I'm just weary that, you know, it's time and time again that consultations are done in good faith, and then the findings just become quite difficult to implement, or they get lost in the whole myriad of process that goes through. Thank you.
Thank you. So, yeah, just on the overall process for how the findings are considered. So the findings consideration panel meetings that we've set up, they aren't mandated as part of the process. We put those in. So before the final business case will be signed off, one of the things that NHS England will want assurance on is that the CCG have taken account of the findings of the consultation. So that's why we put those workshops in, those touch points in. So they aren't large meetings, they're a workshop format. So we have patient representatives there, we have clinicians there and officers from the CCG. In terms of how the findings from the engagement that Health Watch are doing as part of the consultation, one of the things we've asked Health Watch to do is to produce a separate report that sits alongside the core consultation report. And the reason that we've done that is if you put the feedback from those communities in with a wider data set, it's going to get lost, because those conversations are about the quality of the conversation rather than numbers of people who come back. So the format of that engagement is slightly different. We've asked Health Watch to focus on barriers to access and specific vulnerabilities, cultural competency, so things that will affect those communities. They'll produce a separate report. So the findings consideration panels will consider that report alongside the core consultation report. So they carry equal weighting. So we've been quite careful. We could have put the Health Watch data in with the wider consultation feedback, but I think you're right, it get diluted, and it's important those voices are heard. So we'll make sure that those panels have the right source of intelligence to consider, and one of the core bits will be the Health Watch report.
Okay. Councillor Gerling, you are on mute.
Sorry, yeah, are you happy with that answer? Do you have a follow-up question?
I don't have a follow-up question. It is more a comment that while I'm reassured, Lewis, by what you're saying, and that seems, mitigation in part, that the report would, particularly from the seldom heard and vulnerable population, will be sitting alongside and not just be filtrated. So that gives me more assurance. And I suppose if there is, I go back to my previous point that if there is a clearer pathway on how the findings would be implemented, I think that would mitigate, the voice of the vulnerable population, because it's so often, and it's very frustrating for those population who are not engaged in health and social care. It takes a lot for them to give some input. And then if in the entirety it's seen that, well, what I said just didn't get taken on board. While I appreciate that not everything that everybody says gets taken on board, it is just a loss of trust for the population who is not already engaged. So it was just a general comment. But thank you, Councillor Gerling, for giving me that opportunity.
Okay, thank you, Ajanta. That brings me on to Yvonne.
Thank you, Chair. Can you hear me now?
Yeah, yes, we can, Yvonne.
All right, thank you. On listening to this whole report and what's being said, I've got two questions, Chairman, if I may, and I'll ask them both so that it doesn't take up too much time. We're being told that there's 64 beds at this centre, and it's sounding to me as though we have 64 beds for Nottinghamshire, but we haven't, have we? This is a regional centre for the whole of the East Midlands. So why are we closing things down with no surety that we've got beds provided at this centre? And the second question is there any facilities for families to stay over if they are needed to? Thank you, Chairman.
Okay, Chair.
Sorry, I couldn't unmute there for a minute. So the current pre-consultation business case is based on patients that are going through NUH. So because NUH is a major trauma centre, it gets patients from across the region. And so that's the MSK and the neurological patients. What we have got is so we do know that the 21 beds, the 21 Linden Lodge beds will transfer over, and we will have that capacity for Nottinghamshire. And then the unmet needs that I mentioned earlier across neuro patients and MSK will be a combination of Nottinghamshire and patients from other areas. So it will predominantly, based on the current business case, it is predominantly Nottinghamshire patients, and that's because it's patients going through NUH. What we are looking at for the decision-making business case is just looking at the modelling one step further, and what is the demand across the other areas, and how does this centre impact and relate to their current services, so that we can get a further understanding of the demand on the 64 beds. And this is in the context, as mentioned earlier, that there is a concern that is 64 enough, and 64 is what we've got. So have we got the business case right, and do we need to look at and how do we further look at the numbers around the case mix? So I think for assurance point, yes, it does fully include the 21 beds for neuro, and Nottinghamshire won't be losing any beds, but there's further work to be done around the modelling and understanding this as a regional centre, but that is the next phase on. And then your next question was around any facilities for families. Yes, there's a room for families to stay on each of the 3 wards, so there'll be 3 family rooms available, and that's part of the mitigating actions for the travel as well. And that's it. Does that cover it, Yvonne? I think we've lost Councillor Gurley.
Right,
I think
okay, I'm
it's
really
around
sorry
somewhere.
about that. My computer just said that it's not, it went wrong. I'm on somebody else's computer now. So and
no.
then to wipe it because of coronavirus, and then because the keypad was wet, I couldn't move the mouse. Are you happy with that, Yvonne?
Sort of. It's not exactly clear to me about this 64 beds and the regional centre, because East Midlands is a big area, and I'm not sure that we're getting the correct facts here at all. But I'll leave it for now. Thank you, Chairman.
Okay, Yvonne, that brings us on to Councillor Martin next, please.
Right, yes, I'm not sure whether you can hear me or not because my kiosk has disappeared off the screen. Is it working?
Yeah, we can hear you, Councillor. We can hear you.
Yeah. So yeah, I really welcome the centre. I've got a nephew in the paratroop regiment, and I've got a resident who lives on Portland Road who just had to have his feet amputated as a result of a bomb from Afghanistan some 20 years later. So I really welcome it, and I do think, I know there's been a lot of talk about transport, and I do have concerns about transport, like we all do, but we're talking about a state-of-the-art facility here that's going to be second to none in the country. And I think if people really need it, I know Paul, if Paul could have gone there, he would have done, you know what I mean? And I think that's the reality of it. If people really need it, they're going to get to it. I know it's difficult. They're providing facilities for families to stop there as well. So it's a very difficult thing. It's very easy to say, you know, is it big enough? They won't know until they've tried, will they? You know, I mean, I know they can do it on the statistical data. My biggest concern about the facility is, as Councillor Woodhead has just alluded to, it's a regional centre. So I notice on question 21, we've got the rehabilitation facilities. So my question would be around, how real are they? How isolated are they? How realistic are they? Because looking at what Paul's had to do, having his feet amputated, it's a very, very difficult thing to live after on such traumatic operations. And my question, especially regarding what Councillor Wood has just said, is one isolated apartment going to be enough to rehab people, to reintroduce them back into the real world? That would be my biggest concern, taking the transport facilities aside from it, you know what I mean?
And part of this is the clinical case managers, and they're managing the patient through from referral through to post-discharge. And it's really for those reasons, recognizing obviously the need for someone to well, it's to understand their whole circumstances and how best do we support them, and also how are the benefits of rehab continued post-discharge. And so the model includes a multidisciplinary team, which includes social workers, mental health resource, as well as the therapists and the nursing staff. And it is this point to really support the patients right from referral through to post-discharge. So, and I think how isolated it is. I mean, people have said before, you know, it is different to the military, and we recognise it is different to the military. And it's really it's us talking to you, it's us talking to the public, and really understanding what can we do further. And there will be opportunity as this progresses, because we are in the early stages. There'll be further opportunity after the when we're at decision-making business case, and that's been written to discuss this, and indeed after that. So I think we need to see this as a continually evolving picture, but absolutely with your feedback is vital to that.
Yeah, I think, sorry, Councillor Gillen, you're still not on sound-wise.
I am now. Sorry, do you want a supplementary?
Just come back. Yeah, you know, I've still got to ask the question: will one flat in isolation be enough to cope with the patients leaving the facility? And I'm questioning the realism of it, because when they actually come home, they won't have that fleet of ancillary staff around them. They're left to take the rubbish out to the bin. They have to put the washing in, they have to get upstairs to the toilet or whatever, and that's that in a flat. You know, I mean, not all people live in a flat. Is it 2-storey? But I need to know that facility that you're going to create there throws up all real life scenarios, because I'm telling you now, when somebody's had the foot took off and they've got a prosthetic limb and they've got to learn to live with it and do DIY and go shopping and take the bin rubbish out, it's a very different reality. And I need to know that facility is catering for that. And I know we might not have that now, where we are now, but if we're creating a new facility with this kind of money and that kind of tech around it, we ought to be making sure that the pathway out is as realistic as possible, and that it's sufficient enough for the numbers to deal with the patients that are going to come through it.
And I mean, that's absolutely part of rehab, is that getting people back to activities of daily living and what can they do. And so I think the facility actually supports that, as opposed to, so now Linden Lodge, let's say, they haven't got anything like the rehab flats that this has. And so this is an added benefit. But what they do is they will they take people out to their home during their rehab. They take people out to the shops. All that will still continue. No matter where a person lives, you know, so it is all part of the therapy and getting people right for discharge, and then upon discharge ensuring that they've got the support that they need, and that will be facilitated through the clinical case managers. But it's absolutely standard as part of a therapist's role, and the different therapists that are included in the multidisciplinary team. I think that, I mean, the complexity for this, for the regional rehab centre, is it's MSK and neuro rehab, and so that's what we're working through for the workforce plan. Is how do we make sure that we've got the workforce to support the MSK patients with what their needs are, and as you rightly identified, you know, their amputee is very different to a neurological patient going home. So how do we make sure that we're giving them the right support that they need?
Okay, thank you, Chair.
Okay, thank you. I've got Liz Plant next, and she's the last one that's indicated. So if you want to speak, can you put your hand up, please? Thank you, Liz.
Right, thank you, Chair, and apologies because I'm sort of repeating what certainly has been mentioned throughout this discussion. But I mean, I don't think there's anybody that doesn't think that obviously these are state-of-the-art facilities, and we will be very lucky to have them. But I mean, the issues that have constantly come through, obviously, in terms of the consultation, are transportation, how to get there. We have had a bit more detail on that, but I still think that's going to be an issue. But the other thing, obviously, is in terms of the physical rehabilitation, yes, of course, these facilities are going to be state-of-the-art. But the emotional and mental issues of well-being that are so much a part of these traumas, obviously they will, I think they will be addressed as well. But an important part of that is having family and carers around and available to support that. So I'm just going to go back in terms of question 21. For visiting families, there will be overnight accommodation available. That doesn't really tell me very much if and again, obviously I know nothing, very little about the conditions that patients will have, but what I can certainly glean is they are not going to be they're going to be lasting, I don't know, weeks, months, perhaps, certainly long-standing conditions. So having that support is crucial. So I do think there should be a little bit more on that consultation in terms of the possibility of families accessing this accommodation, costs. Is there any, I think we've talked in previous meetings of that accommodation being subsidised. I just think that people need more information on the possibility of that, of having their family, their relatives in this centre and being able to support them in their recovery. Thank you.
Thanks, Liz.
Yeah, and we can look to describing that more through the consultation, so there's that complete understanding of what it means.
I'll just add as well, it's not too late to amend that question slightly. I think we've had a few comments on that and they're all pretty fair. We can put some extra context in the questionnaire so people have got a better understanding of what overnight accommodation means.
Okay, if you do that, that'd be perfect. Do you want to come back, Liz? You need to.
No, I just think there's a need for more information on what that sentence means. And again, do we have any information on whether there is the possibility that or the costs of it, and can in some instances will there be subsidies for that?
So there's no cost to it, to the families for that.
Oh, well, then that's fine. That needs to be clear.
Okay, happy, Liz? Okay, Martin Gately, do you have anything to, any additional comments or questions?
Only very briefly, Chair. I'm sure members will be pleased to hear that the commissioners are taking on board all the points that members have raised today, from travel, seldom heard groups, pathway to implementation, and the rehab and the accommodation. I would perhaps have to say that, having seen a lot of these over the years, I think I'd have to say this is a high quality consultation, and it doesn't shy away from any of the issues or difficult matters in relation to the NRC. I mean, that's probably it for me, really, other than to perhaps ask Lewis, when will the results of the consultation be processed and be able to come back to this committee?
Thank you. So the consultation closes September. I can't remember off the top of my head, it was 11th or the 18th of September. So we've got a fairly short turnaround for the analysis and reporting to enable those panels to look at the findings. So by October, we should have the findings of the consultation. I think we'd want to come back probably in between those workshops on the findings and the final business case. So we can demonstrate how we've kind of mitigated some of the feedback. We'd be quite happy to come either side of those points as well, if that would help.
Can you clarify when that would be then? Because you mentioned different dates there. So
yeah, it would be early October. My apologies. It'd be early October, and then I'd have to check on when the final business case is, but we'll have results available from October.
So, Chairman, I'm just looking. I've got the old version of our work programme in front of me, obviously, and I can see, looking at that, we've got a date in late September and a date in November. We'll perhaps have to have a more detailed conversation about this outside this meeting, but it could be then that we perhaps have a special meeting, I don't know, just devoted to looking at this. That's something I'd have to discuss with the members in due course.
Yeah, I think it's important enough to make sure that the meeting happens at the right time. So if it doesn't fit in with our meeting cycle, I think it would be prudent of us to adjust when that is. So as I say, further consultation about that. Does anybody else have anything to say? Right. I'm just going to sum up a bit then, really. So basically, there's a great concern about the transport element and access to the services there. And also, the understanding that it's a regional centre, and I know you said, Rachel, that it's a regional centre anyway, the service is regional. But the concerns I feel from the committee is that a loss of other services because of this. Can you sort of reassure the committee that actually that's not the case? We will not be losing services to make sure that this can go ahead.
No, we won't be losing services, and the one that's transferring over is Linden Lodge, and we absolutely will be continuing that.
Okay, that's brilliant then. Thank you very much for that. Okay, thank you for coming and doing that presentation. The recommendations are on page 10. And to consider any comments, which we've done, and the schedule and schedules considering of the results of the consultation, which clearly we're going to get back to you. Anybody disagree with any of that? Speak, rather than everybody say yeah. So everybody's happy with that. Perfect. Thank you very much, Rachel and Lewis. Thanks for your time. Really appreciate it. Okay, then. Does that help? All right, I must have leaned on something. Sorry about that. Thank you, thank you, technology. Thank you, Rachel and Lewis, for the presentation and answering all the questions. Okay, that takes us on then to our next item 7, which is the COVID-19 response. To introduce this item with massive impact on everybody's life. Can we keep it local, please, at Nottinghamshire? Yeah, and keep it sort of non-political. Yeah, because that's what we're here for. We're here to make sure that the residents in this county are getting the best advice and best support in terms of the COVID from our people within this place. Sorry, Martin, you want to, Councillor Martin, you want to say something? Take yourself off mute.
Yes, on the item.
All right, okay. Okay, let's have them speak first, but then that'd be great. Okay, right, on this, I think we've got Lucy Dadge, which I can see, or I could see, and Nina Ennis doing this report. So if you'd like to get on with it then, basically. Thank you.
Thank you, Chair. I'm just going to kick off, and Nina and I will take questions, and Nina will also support. So I think you've received a paper on the service changes that we have made during the COVID and in response to the COVID pandemic. So what I'm just going to outline is how we've managed those service changes, how we will restore essential services quickly and safely, and we also might touch on how we might embed some of the changes that have an evidence base of improvement. But if I just start briefly with a bit of the context around the timelines. So it was 30th of January 2020 that the first phase of the NHS's preparation and response to COVID-19 was triggered, and we were placed and remain in a level 4 national incident. On the 21st of February, we had our first confirmed local case in Nottinghamshire of COVID-19. And most significantly, on the 17th of March, we had a letter from the Chief Executive of NHS England asking every part of the NHS to redirect all its staff and resources to managing the incident. And in April, we had the peak of our local incident. At the end of April, then, having passed the peak, we got another letter from NHS England that signalled that whilst we remain in a level 4 national incident and we need to continue all the actions to manage this, we should start to think about how we restore. So I'm not going to talk about individual service changes now, but we're very happy to take questions. I'm just going to set out how our service changes came about and the principles that we applied to them. And then Nina will talk through our approach to restoring services following the peak of COVID. And as I say, we're then happy to take questions. So service changes. It's fair to say that we've only made changes to help manage the impact of COVID-19, particularly the increased demand on our hospitals, and that's not just our acute hospitals, that's our mental health hospital beds as well. Some of the changes that we've made have been mandated nationally. So we were told to do some things. We were told how to manage discharge of patients. We were told that we needed to reduce face-to-face appointments. And also we were given a very clear list of some non-urgent services to postpone. There have also been other changes that have been made by the local system, mainly by the providers, in response to very locally specific circumstances. So particularly local staffing pressures. And most of the changes have been made by our providers, our hospitals and our GPs to manage their workforce and operational pressures, and most importantly to maintain patient safety. So we are now in the restoration phase. So we are actively identifying which service change we should reverse now, and if there are service changes that we should consider to go ahead as part of our longer term changes. And just finally, for me, by way of introduction, we've applied, even in this sort of pandemic crisis situation, we did apply for sort of fairly transparent principles in agreeing to any service changes, and they are all about better patient care. So first and foremost, it was very clear that we had to ensure there was adequate hospital and intensive care capacity for patients who needed acute care as a result of COVID-19. Our second principle was we needed to keep staff and patients safe in healthcare environments, and that includes cohorting infected patients and other infection prevention and control measures, and how we deploy our workforce. Third principle was to reduce face-to-face contacts where care can safely be delivered by alternative methods, but that does not mean we haven't continued to deliver face-to-face care clearly. And finally, a huge amount of work with local authority colleagues, particularly to support the most vulnerable members of our population. So those are the principles that we've applied to all the decisions that we've made. And I'm now going to hand over to Nina to talk about how we are getting into the restoration of services.
Thank you, Lucy. And so, as Lucy said, we're actually in restoration now. And again, we've got principles that we've applied to how we're restoring our services. And the overarching principle, as you would expect, is that we have to focus on safe, effective and compassionate care wherever services are delivered, and rebuild any confidence that's been lost in the public about how safe health services are. We're still feeling some nervousness from some patients who are hesitant to come into health settings. In order to achieve that, there are environmental issues that we need to address across the whole system, so that we can ensure that we have the segregation of different types of capacity for patients with different level of COVID risk in place. So we talk very much around having green capacity. That's where patients we know are not COVID positive. Blue is where we know patients are COVID positive, and then yellow zone where it's not clear whether patients have got COVID or not. And so organising capacity in that way is quite different and brings its own challenges. Alongside that, we also need to make sure that we've got the adequate capacity, because the whole operating model for delivery of healthcare is now very different, with PPE being absolutely essential. But just the time for doffing and donning of PPE takes longer than you would normally have between patients. And that's particularly had an impact both in primary care, but also in the acute setting. And so an example is gastroscopy previously took 15 minutes between patients. Now it's 50 minutes for the actual procedure itself, and then for the donning and doffing and the really rigorous cleaning. And so the time it's taken means that the productivity is now much lower than we've seen previously. And so we're building that into all of our plans as well. And then the final issue that we have to be absolutely clear that we've got the workforce in place to deliver services before we restore. And in fact, a letter's just come out again this morning reminding us that we must do risk assessments for all colleagues who are potentially in the high risk categories, particularly patient, staff in BAME, but some of the other risk groups. And we've been told to model our workforce availability, assuming that 20% will not be working in a face-to-face capacity. So there are some really quite difficult constraints within which we're working. However, clearly we can't wait to restore services for patients. So our priorities absolutely are that we need to restore that confidence for our patients and public that it is safe to access services when they need to access services. But we would be looking to maintain some of the positive changes we've seen in the way patients and clinicians have behaved. So an example is we saw ED attendances drop considerably during the phase 1 of the incident. And it was particularly in the minor presentations where there are alternatives, locations where patients can receive their care. That is something we probably want to keep. Patients need, if I've got a need, it's my need and I want it seen to, but it's seeing that need met in the way that is least risky for the patient and also in the most appropriate location. So using primary care, our urgent treatment centres, not necessarily going into ED. So there's a whole piece that we're working on, and Lewis can talk around some of this as well, about trying to restore that public confidence and understanding what people's experience was during phase 1. Our next priority is we have to make sure we've got the capacity for non-elective admissions, emergency admissions, both COVID and non-COVID. And then we absolutely have to keep patients who've got not emergency but need planned treatments such as cancer treatments, cardiac treatments, but where it's time critical, we have to make sure that patients can still access those. During phase 1 of the incident, we've managed really well in keeping the flow of those cancer treatments going. Once we've done all of that, then the priority moves on to standing up the more routine services. So where we are currently is we're now seeing primary care consultations getting near to pre-COVID levels. I spoke to a GP last week who said she'd had her first normal Monday primary care surgery since the start of the incident, meaning that just the numbers of patients were coming back and the kind of presentations she would have seen previously. 2-week wait referrals for cancer had reduced, but we're now seeing those increasing. It varies by the different tumour sites, but those 2-week wait referrals are now up about 80% of the pre-COVID levels. We're seeing non-elective admissions beginning to increase as well. And so now at NUH, those emergency admissions are at 96% of the volume we saw in February, and a bit lower down at SFH at 82%. And so we are beginning to see that restoration of patients coming through on the emergency and urgent care pathways, which is exactly what we would want. We are keeping up with the cancer treatments, though we do have capacity gaps, particularly in terms of our endoscopy. And if you remember, I used the example of the time taken just for a gastroscopy as opposed pre-COVID and post-COVID, and that really impacts on our capacity. And so we're putting in some returns to NHS England about possibility for additional capacity to help meet those requirements. And that's where we're working at the moment. Lucy talked around the service changes that we have made during phase 1 of the incident, and you've received an update in the papers of all of those different service changes. We've categorised them now into those changes that aren't viable to be maintained. They were absolutely the right thing to do during phase 1, but we're now in restoration. So examples would be stopping of all routine elective activity. Clearly, we don't want that to carry on. The redeployment of staff. Clearly, we don't want that to carry on. There are some changes that probably won't be reversed totally, but they are in line with previous transformation programmes. And an example for that is the volume of non-face-to-face contacts that have happened during this phase 1. That's something we've been wanting to achieve for a long time and made huge progress on it, but we need now to fully understand what that has meant for patients. Are there patients for whom this kind of media just doesn't work, or phone, and really understand what the right balance is between non-face-to-face and face-to-face contacts. And then there are some changes where we just need to understand more whether they need to be restored, i.e. the service reversed, whether they're in line with potential transformation plans. And really that's as far as I would like to go with our progress to date. And as Lucy said, clearly we're happy to take any questions, because that's clearly a very high level overview of where we are.
Lovely. Thank you very much for that, Nina and Lucy. I'm opening up the questions then. Councillor Martin, you was dead keen to get on there.
Right, yeah, sorry, thank you, Chairman. Obviously, you know, we all welcome the gargantuan efforts of the NHS staff throughout this COVID pandemic, you know, and in the week of the 72nd birthday of the NHS, we welcome these reports, but I've got a number of questions, so you might want to write them down. How much has been spent so far on test and trace programme? What is the uptake by area throughout the county? And for example, which areas are the highest and which are the lowest? Regarding the testing, how many tests have been done across the county? What are your thoughts on the weekly testing of NHS staff and how important do you think that is on, you know, on the production, the ability to function? Do you back the campaign to implement weekly testing on NHS staff? And there are currently, like you say, there are currently 2 million people waiting for screening and treatment on cancer. So how confident are you that without weekly testing of NHS staff, that these people will return to the hospitals? Because a lot of these people have had the fear of God put into them over the last few months, and they're frightened to death to come out to the shop, never mind to come into the NHS establishments. And I think it's a really important thing for the mental health and well-being of the NHS staff, as well as the safety and security of the patient. So there you go. Thank you.
Before you, have you got me? Before you answer those questions, I think in your support of or against, I don't think that's relevant. Yeah. That can lead on to go in the wrong direction. Yeah, but you know, keep on with the questions in terms of how much.
It's a valid question.
No, it's not. No, it's not. No, it's not.
Relies on the support of the CCG to back the staff and to test it.
Councillor Martin, it's not about, this is about opinion on whether they think it's right, and I don't think it's good to put them in a position where they have to give that opinion on that. What I am saying is they don't have to answer that.
Good. Thank you, Councillor Martin. Thank you, Chair. Now, I think Nina and I we may not be able to answer all your questions because some of them you want some quite specific detail. We do have a director who is overseeing, in fact, her entire life's work at the moment is the test and trace programme. So I think with regard to your first question, how much has been spent, what's the, you know, how many tests what's the uptake by area? I can't respond to that today. I would be able to get you a detailed response to that probably by the end of the week. So I think that would be, apologies about that. The issue about testing of staff weekly, I wouldn't be qualified, nor would it be appropriate, I don't think, for me to give an opinion. What I would say is that there is a lot of background evidence now that that suggests that the prevalence of COVID in asymptomatically is about 20%. So that's suggesting that 20% any of your staff at any time could be carrying COVID. So it's the asymptomatic patients that we staff we would be concerned about. So I think it is incredibly important that we keep on top of that, because you have two outcomes of not doing. One is that people are transmitting COVID without knowing to patients, or the other is that you've got patients, essential staff isolating because they do not know whether they do or don't have COVID. So I would suggest from the purely evidence-based, it's good to continue that programme. Just a response to your question about treatments of cancer, there's been something in the paper, in the news this week, I think it was yesterday, that said that when we look at next year's excess death review, there could be up to 30,000 excess deaths as a consequence of this pandemic, and that is not a situation anybody would want to find ourselves in. Again, I haven't got exact figures, but what I can tell you is that in terms of treatment, hospital-based treatments for cancer, Nottinghamshire has maintained, it's been the best performing patch in the East and West Midlands, and we continue to do the same number of surgical procedures as we would have done without the COVID pandemic. So we have done very well on that, but clearly we want people, as Nina said, to feel confident to come back to their GPs, to contact their GPs if they think they've got suspected cancer, because, you know, the principle of earliest possible diagnosis holds whether we've got COVID or not. So I think those are the questions I can give, but I can certainly give you a follow-up briefing. I can get something through to Martin on the numerical questions you asked at the outset.
Do you want to come back, Councillor Martin?
Well, yeah, only to say that really weekly testing is really about the mental health and well-being of the actual staff and the surety of mind for those patients who are petrified to come out, you know, and that's what the issue is about. And it's not about, it's a really been a bizarre episode for everybody, and it's about surety of mind for all concerned, and that's my biggest concern.
Thank you for that. I just want to say something before I've gone on to the next speaker. Oh, next question. I think it's a fantastic achievement that you did the same amount of procedures as you were before the COVID pandemic came in. So I just want to congratulate you on that and leading the way in the East and West Midlands. So thank you. That's really reassuring that you've been getting on and doing what you need to do. So thank you. Next question then from Ajanta, please.
Thank you, Chair. I would echo what Councillor Girling has just said, that yes, it seems that regionally there has been a big move to carry on with, especially with the restoration. I have a three-part question, three different areas, I'm afraid, Lucy and Nina. One is that you have mentioned in the consultation in the report, not so much in your presentation today, that the care home staff and the residents in the care home, there is now testing for both the care home staff as well as the residents when they show the symptoms, and they will be swiftly tested. I wonder if there is something, especially to the care home staff, of asymptomatic and hence a routine weekly test mechanism being considered or in the pipeline, just to mitigate that as it is for the NHS staff. The second point is moving away from test and trace to cancer, and thank you very much for updating that the cancer procedures have been the same with or without the COVID. However, my question is on the the referral is the 2-week wait. That nationally is around 80% are meeting within the 2-week, and I wonder if you're able to give us some information that is, is the county 2-week wait also in line with the national data of 80%. I can further clarify the question if it is needed, but I get a sense that, Lucy, you understand what I'm asking. And my third question is that as we are moving into the restoration and we are mindful of perhaps, maybe not, but if there is any reason for local lockdown, then the specific language requirements during the first lockdown, Health Watch, when we did a quick COVID survey on did you receive the information, did you understand whether you are required to lock down, individuals who had populations who had language issues and language requirement, they failed to understand what the message was. So would that be, is there any mitigation if there is any requirement for local lockdown? Thank you.
Yes, so I'm sure Nina will support particularly with the cancer question. So asymptomatic testing of care home staff. I'm afraid I don't know the answer to that. I don't know whether you do you, Nina? But I would agree that it would be extremely helpful in the same way as with NHS staff. Do you have a...
Yes, the testing programme is rolled out to care homes, and locally we were trying to make sure that the testing was taken into care homes to make it as easy as possible for staff to take up that offer of testing, rather than requiring staff to either use the home kits or to attend one of the testing centres. So I know that we are doing it. I can't say if we're doing, and we had prioritised those homes where they had a higher number of patients with COVID, but I can't be certain about the frequency with which we're providing that testing, but it is certainly within the whole programme of testing.
Thank you, Nina. Your cancer question, which I'm sure Nina can support with, I think our referrals from general practice were down in line with the national trend. I don't think we were an outlier, so I think we thought 75% reduction in normal 2-week wait referrals, and clearly that is a key area of focus. Probably my other comment on that would be that a lot of not all cancers are picked up through 2-week waits. So it is really important to get those 2-week wait referrals up to where they were, remembering that probably only 2% of those will convert to a diagnosis of cancer. But I think I'm right in saying, Nina, more cancers are picked up through routine and people attending ED than are through 2-week wait. So it's not to diminish the importance of the 2-week wait pathway, but actually it's as important to to restore all those other routes into healthcare to make sure that we don't fall victim to a lot of missed or late diagnosed cancers. Have you got anything you wanted to add to that, Nina?
Just a slight bit of detail. So in April, we had gone down to 60% of 2-week wait referrals compared to pre-COVID levels. So we weren't quite as bad as some of the national picture. We've now increased the number of referrals that are being through. So we're now seeing about 80% of our normal 2-week wait referrals. But our emphasis is very much on trying to get patients to go to primary care if they think they know they've got a concern, so we can go down the 2-week wait referral path. But as Lucy says, currently we are still picking up a lot of patients who aren't referred down that route. So that's why it's so important we restore confidence to the public to be able to access services if they need to via emergency admissions.
And one of the sort of positive things that we have managed to do is our very high risk pathways for cancer treatment. Patients have actually, with the capacity that we've been able to protect, some of those pathways, patients have been seen quicker than normal. So just finally on your point about if we have another lockdown, ensuring vulnerable patients have all of the information they require, and particularly those patients that may need information providing in a different form. That is very more support. That is very much recognised. I mean, I think nationally there was a huge amount of learning in the first couple of weeks actually about accessing vulnerable patients, giving clear messages, and absolutely I think we are taking the lessons from that into what we hope won't be another lockdown. But clearly Health Watch are somebody we would want to constantly take your insights on that.
Okay, Ajanta, have you got any supplementary questions?
No, thank you, Chair.
I've got you, Yvonne. I'm just so everybody knows, I've got Kevin, Stuart, Martin Wright, Richard, Yvonne, and then Councillor Martin. Okay, so that's Kevin next, please.
Thank you, Chair. Can I just start by congratulating the care home staff that many have gone beyond the call of their duty, with some staff actually living in care homes to protect the residents. And we should collectively be congratulating these people. And so one of the questions is, how prepared are we for a second wave of this virus that many believe will be coming later on this year? And can I also go on to testing on page 78 of the yellow pages there, the fourth bullet point down, I think it is 1, 2, 3, third bullet point down, sorry. How quickly are we getting the test results back to patients at the moment? And on the next bullet point, it says we are working to roll out antibody tests. Have we got a date for that, when that will be running? Can you give us a date on that, please? Thank you, Chair.
Yeah, thanks. I can answer the one about how long do you get your result, because I had to be tested and it was 24 hours. So it's immensely quick. So that's a great response, actually, because I had to have my test because I was having an operation and I had to be tested before I could go to the hospital. And I got it within 24 hours. And if they're doing that across the piece, which we're going to find out, that's a fantastically quick response, I think.
Yeah, and it should be within 48 hours, but most people are finding 24 hours. So if I answer your question about care homes, so again, we have learned an awful lot about care homes and what an essential part of our overall health and care system they are. And I'm sure that they will be part of the system going forwards in a way that they haven't been before. So I think that has been great. We have put additional support into our care homes. So examples are every care home in the county has an identified clinical lead, so somebody that they can go to in the CCG for support if they need it. Every care home has a weekly check-in or ward round. It's also described as to review patients identified as clinical priority for assessment and care. So that's not to suggest that individual patients haven't always been cared for by their own registered GP, but there's now this ward round on top of that. We've developed personal care plans and support plans for care home residents. So every care home resident has to have. And again, you know, this was always good practice, but this is something we can be confident we are rigorously doing, and we are reporting on all of these measures on a weekly basis. And there's also a lot of effort gone into pharmacy and medication review and support in care homes. So those are the 4 major changes that we've made. But I think most importantly, I think we've taken the care homes into our NHS family. But they are things that will, I think, will serve us very well. Winter, we don't know, do we, whether there'll be another surge. I couldn't possibly predict that, but we are expecting a winter with our seasonal flu and some level of prevalence of COVID. So it's going to be a difficult winter, and keeping care homes safe and for patients has to be one of our priorities. I'm afraid I am not able to ask, but there is a lot of work underway about antibody testing, both how to do it, how to get it reported, and actually the question of whether having antibodies for the virus affords you longer term protection. But again, if we do the briefing on testing, I'll make sure that we put in that a timeline for rolling out antibody testing in Nottinghamshire.
Are you happy with that, Kevin, or you got a supplementary?
Yeah, just a supplementary, Chair, if you would. After all this has been rolled out, will there be a report coming to this committee just to analyse where we could have done better at all, Chair?
Yeah, I think it's absolutely essential that we do have a paper on lessons learnt. I think with something of this scale, there'll always be things that haven't worked what we thought might, the things that haven't gone the way we thought they might, but there'll be also some very positive lessons that things work that we might not have expected to work as well. And I think it'll be really beneficial that once we get over it as much as we're going to get over it. I don't know if this is going to be something that's going to roll on for a very, very long time, or it's going to be something that just becomes another flu, if you like. What I am keen that happens for us as a committee, that it happens in good time, but not where it's detrimental to the staff doing what they need to be doing. Yeah, so absolutely, Kevin, I'd absolutely push for that we get that. I hope that answers your question. Lovely. That brings us on then to Stuart Wallace, please.
Thank you, Chairman. Hello, Lucy. No, it's nice to see you. Can I start off with something you at the end of your comments, that of the influenza, and it's the main thing I wanted to discuss, is that we know that influenza will come back. We know that Nottinghamshire doesn't have a very good record of immunisation of its population. It's less than 56%. We know that the COVID and influenza are very, very close to each other. So together they should make a rather devastating ability to get round. We know that we're still as vulnerable as ever we've been with our population. There's no alternative vaccination. How and what are we doing, and what CCG doing in preparation to try this time to get the numbers of people injected with vaccines for the flu. That's the main comment I would make. Moving on, secondly, I love statistics. I really do love figures. I have been totally unable at any time to try and nail down any figures that we get regarding Pillar 1, Pillar 2 and what's been happening in the county. Because one thing comes out with a set of statistics, etc. But when you do the mathematics of it, you're told that the numbers in Pillar 1 against Pillar 2 are this and this, but they're not. There's something changed over. Because I asked for the simple thing, and I still haven't been able to get it, is statistics that I could rely on to tell me what's happening in my district council area, and particularly my town in which I respond, because I think it's important that if we know that we've got clusters, if we know we've got areas which are problematic to us, then we can use our own information as well and try and move it on. My third comment would be, and I take all the information on the care homes, but we're still not thinking about home care. We fall into a trap of saying, well, people are either in hospital because they're ancient or in need. They're in care homes because they need help. But we forget that the majority of people are being looked after by their partner or members of the family. So how are we testing the people that go to give home care support? And how are we making sure that they do get the right feeding? I know that letters went out from GPs, surgeries, etc., from wherever, giving advice and stuff, but we're not testing them, we're not seeing them. And that is another block of people who are totally vulnerable. Thank you. Also, Nina, nice to see you as well.
Thank you, Councillor Wallace. It's lovely to see you. On flu, I'm afraid I haven't got my numbers at my fingertips, but normally we have a target of vaccinating sort of 65% of our population, and you're quite right, we've not quite hit that in recent years. It is absolutely clear from NHS England that that will not do this winter. We are going to be I mean, clearly you want to vaccinate 100% of your population, but we will be looking at probably 80% cover. We're working through, of course, this is another job for our very hard-pressed GPs. So the two things to get as many people vaccinated as you possibly can is to make sure you can get hold of the vaccine. And when you've got hold of the vaccine, that you are as ingenious as you can be about how people get vaccinated. And that might mean not going to your GP. That's going to mean all sorts of different ways, including, I understand, self-vaccination has been thought about. So we can give you more on that, Councillor Wallace, but that is a very emerging issue nationally and locally, and it will be absolutely critical to getting us through this winter. You are right. I don't know, Nina, have you got anything you wanted to add on that item? Sorry.
You need to unmute yourself, Nina, please.
Yeah, I apologise. I was just going to say the focus on it is relentless in trying to make sure that we have the capacity to deliver, but it is dependent on so many different factors.
So that's dealing with that one. I think we'll take away from this discussion the need to actually get that data out there about local clusters, Pillar 1, Pillar 2, effectiveness of testing, both at county and at district and borough level, and we can feed back to you that on that, I think, separately. As far as home care is concerned, you are absolutely right. There's a huge amount of care is provided in the home. One of the things as a CCG that we've actually done, as opposed to commissioned, is we've personally organised the delivery of PPE to people in their homes. So every day we are distributing PPE to ensure that carers who are looking after relatives with COVID have the adequate protection. And again, obviously a significant part of that process as well is to make sure that we're constantly testing and making testing as accessible as possible. But you are absolutely right, they are, if we're not careful, they're a hidden group. The home carers are a hidden group in our system.
Any comeback, Stuart?
No, not other than to say thank you very much.
Okay, Nina, thank you very, very much for not saying it was good to see you too to Councillor Wallace. So well done for that. Councillor Martin Wright, please.
Thank you, Chairman, and it's fantastic to see Lucy and Nina there today because we always like them to come to our meetings. Councillor Wallace again has stolen a little bit of my questioning on the seasonal flu vaccinations, and I'm very pleased that greater effort is going to be made to try and increase the number of people who are vaccinated. My 2 points are: firstly, thank you for this list of service changes made to support the COVID response, and I do note that we have had briefings on quite a few of them, but I also note that we haven't had briefings on the majority of them, and that was obviously due to the time constrictions. But what I'd like to ask Lucy is how many of these temporary changes are likely to be permanent changes, and in particular, something that's quite close to my heart, Chatsworth Ward, will that be restored to its former glory after the COVID crisis? Thank you very much, Chairman.
Thank you for your question. So I would say, and again, Nina might want to correct me, looking at the list, the majority of there are very few, if indeed any, that I think will be permanent closures. So I think you can be rest assured that these are those that haven't already been reversed. So, for example, the home births, suspension of home births at Sherwood Forest Hospitals has already been reversed. There are others that have already been reversed. Clearly, things like CAMS in-reach support to schools, all those sorts of things. These will all become I think, looking at the list, they will all be restored. With regard to your particular request about Chatsworth, so I've been on this journey with you, haven't I? And I remember coming to the Scrutiny Committee. I didn't check my notes adequately this morning, but I think it was January 2018 when we said that ultimately a robust community rehab service was what we wanted to provide and not rely on beds, which actually is even more pertinent as we develop the NRC, and also as we learn about how people rehabilitate from COVID, which I think somebody mentioned earlier in the meeting. So the direction of travel has always been to have a robust community service and not rely on those beds. However, we aren't at that position at the moment. Patients were discharged from those beds at the beginning of COVID because it was clear that being in an institutional hospital setting was not good for patients who absolutely didn't need to be there and for whom care could be provided elsewhere. Rest assured, Councillor Wright, that if it proves that the care has been provided better for those remaining beds in the community, and our request is to continue, to make that change permanent, we will be coming back to you. So I think we're not trying to get that one past you. It was just that was a COVID response, but we will come back to advise you if we think that's a permanent closure.
Thank you very much. Thank you.
Are you happy with that, Martin?
Yes, Chairman. Yes, thank you.
Lovely. Richard next then, please. Richard, you need to take yourself off mute. I'm sure that was really interesting, but we didn't hear it.
It was fascinating. Sorry about that. Thank you, Mr. Chairman. Well, joining in with everyone else who's pleased to see everyone, I'm also pleased to see everybody, not just individual named people at the meeting. Truly extraordinary times. I'm looking at page 77 on the yellow pages and the various bullet points, and what a drastic way to get a comment that says we're seeing less inappropriate attendances at A&E. How many times over the years of this committee have we raised concerns about inappropriate turn-ups at A&E, and now that's happening, but what a drastic way to get that. But what I wanted to pick up on is a couple of things, actually. In one of the bullet points, it refers to a reduction in people not attending GP practices and people who may have low or moderate health concerns or even mental health concerns. But then in a couple of other points further down, we're now saying we are now starting to see a rise in attendances at GP practices in A&E. So is the reason for that mainly because people are starting to feel a little bit more confident about coming out, or is it down to promotions, publicity, but also linked to that, looking to the future, is one of the new way of working has seen an increase in online and video and telephone consultations with the GPs. Now, that's an area which, for obvious reasons, hasn't really been looked at by this committee or anyone else yet, because it's all happened so quickly. Is that something that is likely to carry on more and more, even or if we get over this current crisis? And if so, is it something that needs to be looked at a little bit closely? Because I still suspect that there's a lot of people out there who would not want to use or not feel happy about using online or telephone consultations. Thank you.
I think I can take your question in two halves. So if you talk about general practice, we've got no data to suggest that the number of contacts with GPs ever changed. So from day one, most general practice went online or telephone consultation. So we didn't see the reduction in people seeking advice from their GP. We just clearly saw the reduction in people feeling confident, and rightly so, that they should go to a GP, sit in a quite crowded waiting room for a condition that could be managed by the telephone. So first and foremost, GPs carried on working really hard, but most of it was on the phone or by video. I think the statement that you're referring to, what that's saying is people are now feeling more confident to go back in to their GP for face-to-face appointments. I think most general practitioners would say, if you are able, even now when the background environment is safer, if you are able to have your problem dealt with over the phone, that is probably better. But please don't, ring the surgery and you will be told whether you need to come in. Your specific question on that, then, do we think that is something that will continue? I think that's very much for each part of our system. We've set up what we've called a recovery group. So looking at how have things changed, what things do we just need to restore as they were, which is restoration, and what things might we want to recover in a different way. And I think you are right that different ways of accessing normal general practice, through telephony, through video consultations, through remote monitoring, because we did a lot of remote monitoring. I think general practitioners as a group professionally feel that they can give more care and probably absolutely as good care by doing more remote work. And if that is a subject that the committee would like to understand in more detail, we'd be very happy to come. So I think, yes, in principle, I'm sure there won't be the vast majority of care provided remotely, but I think a lot of it will. So hopefully that answers that question. Is that okay?
Yeah, that's through you, Chairman. That is very helpful. I think it's something that does need to be looked at, because I would still worry about a key proportion of our community, and I'm not being particularly ageist here, but I am thinking particularly of the older community, who on the one hand will be understandably worried about going to the GP surgery because of what we're all going through at the moment, and they'll be feeling insecure. But on the other hand, they will still feel less than confident about using the new way of working and all the rest of it. So it's a way of how that's managed and how the message is got across to them. And I realise that's not going to be easy, but it's something I think that probably does need to be looked at.
Yeah, I mean, yes, and I absolutely agree with you. And I mean, people have different ways of interacting with technology. People that live on their own. I mean, I asked a GP about, what would you do if my tonsils were inflamed, if you couldn't see them? And he'd say, well, I'd ask your daughter to look at your tonsils and say, have you got any white bits on them? He said, that's all I would do. And I thought that's a fair point. But if somebody that lives on their own, that might not be as easy. So I think you're absolutely right. We can't assume that this remote way of working will suit everybody forever, but we would like to. There's a lot of things that the care can be provided as well, and we can treat more people. The other thing to say about the remote working with general practice, it's been really helpful for GPs. We would have lost a significant amount of our workforce, because we have pregnant GPs, we have GPs with their own long-term health conditions. We've had the emerging information around vulnerability of Black and Asian minority ethnic GPs. So actually allowing GPs to work remotely because they've wanted to carry on working. So there is that side of it, that in a crisis like this, the fact that we've been able to mobilise technology quickly, that's kept the amount of GPs available to at least treat people remotely online. I mean, your question about ED presentations, I mean, it's always tricky, isn't it? Because you'd like to think, I hate putting words like inappropriate in a paper, because you'd like to think, using your own values, that nobody would go to ED if they didn't have to. Some people do because they can't get care any other way. But we are, again, as a follow-up to what we've learned, looking at ways of making people feel more confident to use the services like 111, and actually getting proper clinical assessment so that people can use that first. And that doesn't mean you wouldn't still get referred to ED, but then you might go with a booked appointment. Now, clearly, if your arm is at 90 degrees to where it should be, you're going to go to ED. But if it's another presentation that needs an appointment at ED, then there could be an opportunity to say, actually, we'll properly clinically triage people and book them in so that you're booked in before you get there. But that, again, that sort of thing is all part of our emerging thinking.
Dare I add to that with the, until very recently, the shutdown of the pubs and the clubs and all the rest of it, could that be a reason why there's been I'm not being frivolous, but we all know what happens on Friday and Saturday nights. So what will happen when and if they all start opening up properly again, I think will be an interesting time.
And also the student population has diminished.
Oh, indeed, yeah.
And that's had an impact. Yeah.
Okay, thank you.
Well, thank you, Richard. I'm going to interject here because I've had some personal experience over the last few weeks in terms of being able to get an appointment with my doctor. Lot easier, and it was all done remotely initially, but I did have to go in and see them. And in terms of the grey population, if you like, using technology, I'm a chairman of a charity that looks after injured veterans, and some of them, one of them is 94, a lot of them are in their late 80s, and we do a regular Zoom meeting once a week with them. Initially, it was a bit of a difficulty, but actually, I think you'll find because of this pandemic, the more elderly people are actually got to do it, so they can speak to the grandchildren, so they can speak to the children and all that sort of thing. So I think that's one of the good things that's come out of this pandemic is the older people. I don't know if that's politically correct to call them older, but I'm getting into that category anyway, so I can say it. Are actually using technology to communicate with the family. So I know there'll be cases where some don't, and they're the ones we've got to look out for. But I would suggest that a lot more people are able to use that remote access now in the higher age bracket. Okay, so Yvonne, you're next.
Thank you, Chairman. Several things, really. First of all, congratulations to all our NHS staff for the work they've done. We couldn't have done anything without any of them. So big congratulations to all of them. The second thing I want to ask you about is the fact that Blidworth surgery closed and all our patients were sent to Ravenshead surgery, which is not on a bus route. So we've had extreme difficulties getting people to surgeries, to the point where we've had to set up a charity and get a vehicle so that we can actually get people to and from the surgery at Ravenshead, which I think is absolutely deplorable, considering that Blidworth has a brand new state-of-the-art surgery, more than fit for purpose. So I think that's a really bad thing that's happened to us here in Blidworth. And then the flu jabs. Well, I'm not a fan. I had a flu jab and a pneumonia jab in September 2010, and I've never been well since. And I've had 4 bouts of pneumonia. So if my doctor's going to say to me, you have this jab, I'll make sure he has it instead. Thank you very much, Chairman. That's all I want to say.
I hope I'm not in the surgery when you do that, Yvonne. Thank you.
Oh, I'll invite you, Keith.
Do you have anything to say to that, Lucy and Nina?
I'll look into the Blidworth and Ravenshead issue, because I think the paper describes that there are occasions where either because of the environment or because of the workforce, general practices have had to join together into things called clinical management centres, where one site might have to close and services be provided from another. And that is very much will only be done as a last resort when, for whatever reason, general practice can't carry on to be being provided from that site. Now, if it's not the premises at Blidworth, I can only imagine it was workforce shortages, but I will look into that, because it certainly was never be. I mean, the intention, that's not done for anybody's convenience. It's always a last resort when we do that. And if it's resulted in patients then not being able to access, it's a safety thing. It's we either don't have enough GPs or we don't think this building can manage COVID and non-COVID patients safely, that would happen. So I will look into that.
Are you okay with that, Yvonne, or do you want to come back?
Well, yes, I'm okay with it, but as I said, we've had to set up this charity for a vehicle. Now, this was closed early on in the COVID pandemic. And we've had people that can't physically walk, but they're still being expected to go to Ravenshead. It's been an absolute nightmare. And Gilly Hagan, I don't know if you know Gilly, she's been absolutely wonderful in setting this charity up and getting people out of Blidworth to the surgery and back again, and even to hospitals and back again, because we've been really stuck here. But thank you for looking into it, Lucy. I appreciate that. Thank you, Chairman.
Okay, thank you for that. Muriel, you're next.
Yeah, thank you, Chair. Yeah. And I just want to echo what Keith and others have said. I think we in the county, in Notts, have been so well served by the partnership between yourselves and the local authority and public health. It's not been like that in other parts of the country, and I think it has a lot. It says a lot about the work you've done together over recent years. That it's come home to kind of bear fruit in these challenging times. I've got 3 or 4 questions just across the categories that you talked about. The first one was about the enhanced care from GPs to care homes. I know that the links have been set up in the past, haven't they, so that any particular home has consistent contact with the GP, so that they can make decisions about going to hospital and so on. So I just wondered if what you're expecting more from that linkage. The next question is about the single discharge pathway. I mean, clearly the unexpected and sudden discharge of so many people from hospitals into the care system was a huge challenge. And again, I think your partnership in all that worked extremely well. But I just wondered, what's the thinking behind having a single discharge pathway rather than, as I understand it, the pathway being slightly different from NUH and Central Notts. A question about the recovery colleges that have worked so very well in giving long-term support to people. What have you picked up about the mental health needs of people while the recovery colleges have been closed? And have you got a sense of when they might be able to meet again? In terms of the termination of the suspension of terminations in the pregnancy service, I see that has now been recommenced from beginning of June. I just wondered what's happened about the because obviously the time scale for terminations is very precise, isn't it? I just wondered how the catch-up has been. Have there been situations where the delay for people has been too late, and how's the service responding to that? And finally, these out of hospital community services, particularly for children and young people. 3 or 4 weeks ago, I had a few queries from women who'd had where their children had been born during the clampdown, and they were worried about the absence of visits from the health visitor, and 1 or 2 who would have expected the babies to be looked at back at the hospital had not been called in again. And then I heard kind of different stories from somebody in Hucknall and somebody in Gedling, and I just wondered if health visitors have been kind of making local decisions about what they can and can't respond to, or do you have a concern about that? So sorry, it's a bit of a scatter, but thank you.
So in the interest of time, I'm going to split these with Nina and I. So the care homes, councillor-wise, you will know from your long experience, actually aligning care homes to GP practices is really hard, because you get geographical areas where there might be a lot of care homes, but all served by one GP versus. So that is a really tricky one, and Councillor Doddy will understand that from his day job. In summary, I think what the 4 things that we're doing now are about proactive management of patients in care homes as opposed to reactive. So actually going in, looking at people's medication, developing so it's, the 4 things I described are more about intervening early as opposed to the perfectly normal and general practice support care homes. That would be my feeling. It's a work in progress, but I think it's really, and also helping manage end of life, because clearly we don't want patients conveying from care homes at the end of life ever, and certainly not now. So that would be that one that I would cover. I'm going to ask Nina to pick up the discharge pathway, if that's okay. If I just cover a couple of others myself. Mental health is I'm offering up all sorts of things for your agenda, but I would say that is another agenda item in itself. We've got a huge amount of data now about mental health impacts of COVID, and this is an area where we're learning, and it's not necessarily what we'd expected. Clearly, there are the mental health impacts of people that have spent a long time in hospital or in ITU. There is a huge increase in adolescent mental health issues. People have mental health issues arising out of unemployment or uncertainty around unemployment. As you know, there have been issues around significant spikes in domestic abuse. You wrap all that up, and we think that we are planning for what we think is about a 20% increase in overall mental health interventions. But we have a very detailed piece of research work, so I'm just looking at over my shoulder, that kind of striates what the evidence is telling us. But just to say, it's a huge area that we could, but in general terms, about 20% more support we think we're going to need to offer to people. But I'm sure we could come back and do a session on that, because I think we couldn't do it justice on its own. Termination of pregnancy is a provider that was suspended. There was still a provider of termination of pregnancy services, wasn't there, at Nina? So in agreeing that particular provider to suspend, we didn't feel that we were putting people in a position where they would not be able to access an early termination, and because your points are absolutely right. So it wasn't all termination of pregnancy service, it was just one provider. If Nina picks up discharges, Nina, do you feel comfortable to cover that? Is that all right? Okay.
Yeah, that's fine. So for discharges, there is a national model for discharges, but there are local nuances from NUH in Sherwood at the moment. Whilst we're still working through the incident, the systems agreed that for the time being we will work in the NUH and SFH processes, but get them as slick as we can. But the absolute intention is that we will bring them into a single process moving forward. So for expediency, we're building on what's there already, but there's so much learning and huge progress has been made. And then the strategic intention is that we bring it into one. And you also asked about the health visitor differences. they shouldn't be making local decisions. There was a very detailed guidance came down from NHS-E&I around community services, including health visiting, as to what could be carried on and what should be put on hold. Health visiting is a Public Health Commission service rather than ourselves commissioning it, but we can look into that. But no, we shouldn't be seeing those local differences. So we'll look into that.
Thank you.
Are you okay with that, Mira, or have you got to follow on? Do you have a follow on?
That's really helpful. And I take Lucy's point that actually a paper on the mental health aspects would be very welcome, wouldn't it? It's an agenda item.
Yeah,
Thank you both.
Okay, that brings us on to Liz then, please.
Yeah, thank you, Chair. Well, actually, my concerns and questions were really on the mental health changes, the mental health issues, and obviously, I mean, and I certainly welcome an actual agenda item on that in itself, because I think, you know, the hidden harm that's sort of out there regarding this issue is really going to come back and bite us, really, because people just haven't had the support that they needed. Even with issues that were actually obviously nothing to do with COVID, but if we add that to it as well, there's going to be a perfect storm out there, I think. So I would really welcome that. My other point really was, you know, to add obviously to the congratulations in terms of all the hard work. I mean, I think in the past the NHS has been sort of criticised as sort of quite slow to change and adapt. And yet, obviously, it has shown during the past couple of months how quickly it can step up to the plate and the tremendous job it's actually done. So I'm wondering, Chair, if there's some way we can, you know, actually verbalise our congratulations, really, and certainly have it minuted. Where's he gone? Is that, you know, or put it in writing, certainly, because obviously these are extraordinary times and we've had an extraordinary response. I'm also, and again, this is not really in this issue, but my other concern is obviously the impact on staff's well-being of actually, you know, going through this crisis, and what sort of support and facilities have been put in place to address that. Thank you.
So I think I can answer all of your questions. So and I think if we were to come back, it would be really helpful to come back with Nottinghamshire Healthcare, who are our mental health provider, because they have they've come to us and said they want to set up a programme which has the hashtag no going back. They feel that the advances they've made in provision of mental health services are definitely things we shouldn't be reversing. Giving a quick example, we've been working for some time to get a 24/7 all age crisis helpline in place, and they managed to get that in place within the first month of the crisis, which has been hugely helpful. So that I think absolutely very happy to do that, but I think it shouldn't just be a commissioner perspective. I think that should be the providers, because I think they would add a real richness to that. In terms of staff mental well-being, you are absolutely right. Each of the providers have set up their own services, and they're all slightly different, but they do and obviously different parts of, if you work in a hospital, your needs, if you work on ITU, might be different to your needs if you work on a general ward or if you work on a ward that hasn't had COVID patients. So the hospitals, I do know, have set up their own centres. I know Queen's, for example, has a kind of place where you can just go and talk, and it's mental health first aid, I think they describe it as. But when we do if we come back to you and do a full session on mental health, there is a particular element around ongoing. There is a work stream, I don't like to use that word, on staff mental health now and in the future. So that is part, and again we've got some really rich data on that, because it won't just be now, it will be longer term. And also we've got staff dealing with we're dealing with COVID. You know, you've got people on the front line in ITU dealing with unprecedented clinical issues. You've got people with staff who may have relatives and caring responsibilities that have been exacerbated by COVID. And also you've got the general practice who we've described. They've had to totally change the way they work, but we have got a large part of our workforce who are having to adapt to working in new ways. So there are a whole different. It's not just that kind of frontline bit, and it is really key.
You happy with that, Liz? Lovely. That brings us on to John Doddy then, please.
Yeah, just unmuting there. I've missed a bit in the middle because the computer went flat. This is the problem with technology. But I'll hopefully not repeat anything that anybody else has been dealing with. We were here, one of the CMC centres set up should it be needed. And there was a number of infrastructure changes to create the red areas, amber areas and green areas to provide a really safe environment for people to be able to access, and that's still available going through winter should those type of things occur. I wanted to pick up on a point that somebody made earlier on about their surgery being moved and having to go here and go there. I went to a GP surgery the other day, and you had to ring the doorbell because you can't go into a GP surgery nowadays. You have to almost have a golden ticket. So I got there and I pressed on the button, and it was raining. And there was no awning, there was no protection, and other people were coming up behind me. And I just sort of thought, on a rainy day, a family, people pushing a pushchair, there was an infrastructure problem here, which highlights, I think, the fact that all practices are not equal. And I sort of felt very sorry for people who did that, who themselves may be ill, but I had to wait there and the window was open. So the idea that people would be conversed with through the window as opposed to the door being open and let in. And I thought that, Lucy, that's a very good opportunity for us to look at the infrastructure in Nottinghamshire, to look at the facilities going forward, because if we do have a second wave, it will be access that will be key. It will be safety that will be key. It will be the ability to have the flow through green, amber and red areas. And I think it's a little bit like the pubs reopening. Some of them can reopen safely, and some of them are so designed to have people crowded into them that they'll never be able to reopen safely. It doesn't mean that you can't get a good pint in both the pubs, but they don't actually lean themselves to adaptation towards dealing with the COVID crisis. I do think it's very important as we go forward to not lose the lovely advances. If you look at this screen today and I was to look around, could I safely make a diagnosis of most of the people that I see on my screen today because of the quality of the picture? Very highly likely. And as technology improves and the camera improves, it's allowed us to function at almost a normal level. In reality, from all the years of the use of technology, somewhere between 30 and 38% of contacts with GPs actually translate into face-to-face consultations. And strangely, that's very, very similar to what I'm doing every day. I'll triage a big long list and I'll probably bring a third of the people down. And I think that over history, I think that will continue. And I think people have really, really embraced it. I'm going to be very specific, Lucy, in one of your points here. You said that we recognise that antibody blood tests will need to be taken by trained professionals. We are working to increase the phlebotomy capacity. I'm going to tie you down to tell me exactly what you've done in terms of actually improving that capacity, because we're already seeing the demand and people want to be tested, and there's a great curiosity. How much use antibody testing is, we'll find out in the fullness of time. But it is just a mechanical fact that does exist. I wanted to also get your impression on the critical services return to normality. There has been a fantastic response. I think Nottinghamshire was brilliant. I think we've protected the health and well-being of people exceptionally well. There have been 11-hour days, I can tell you. They've been really, really tough days. When do you think critical services will be fully restored? You say that you're working on a programme over the next 2 weeks. What's your timescale? Because we can't have the recovery process ahead of the critical recovery process, so they have to be taken in steps. So at the moment, if I want to refer anybody for an X-ray, anybody for a test, unless I put on that test that this is critically urgent, it gets bounced back to me. So the critical recovery period is very important, because we want to follow that with the normal recovery for the normal provision of services. So I'm going to try and tie it down to when you think that that might actually occur. And just to say that some services are naturally suited to communication and some are not. I mean, physiotherapy over the phone must be one of the most challenging things that you could ever ask anybody to do. So I think that there's a lot of services that will not be able to adapt to remote medicine. But overall, I think my impression has been enormously favourable towards how things have gone on in Nottinghamshire on the front line, dealing with people day in, day out. I think we've done remarkably well as a county. So over to you, Lucy.
So on the when will services restore question, Nina has much of that detail at her fingertips in a way that I wouldn't, other than as soon as possible. Initially, it was intended that restoration would have sort of taken place by June. By July, we'd be into recovery. I think it has to be said, and again, it's been in the media, hasn't it, that there are some rate limiting factors. Some, you will know, Councillor Doddy, as a clinician, that some procedures like invasive procedures that generate aerosol, we just cannot do at the rate that we did them with the same infrastructure, and the loss of productivity is quite significant. So you just cannot do as many endoscopies, you cannot do as many procedures with the infrastructure that we've got. So clearly we're making sure that the most high risk procedures are done as quickly as possible. But if you'll also probably know from recent media that we're planning for the NHS to get a settlement this winter that means it can actually increase capacity to get back to normal. So I think what I'm trying to say in short term is, whilst COVID's around, we are going to need more physical capacity to do the same amount of work, and that's just a fact of what we know about how the disease spreads. We're hopeful that we'll hear about that over this month, but you've seen what's been in the media. And just to say, given CCG's particular relationship with general practice, in looking for investment in the estate, we have included primary care. We took a choice to say, actually, you know, our clinical chairs are clear that the primary care estate, as you've described, has to be configured differently. So if we get any money, there will be a share of that goes to primary care. But Nina, have you got anything more to say about the trajectory for restoration?
It's the high level is that by the end of this month we would hope to have had the majority of the essential services back online. But as you know, the plethora of services, there will be differences. The big problem we've got is the diagnostic capacity, where we are just holding our own with the very essential and urgent. But that's where we are reliant on trying to get more additional capacity. I don't think we've mentioned that we have been working with our independent sector providers who have been under contract with NHS nationally.
Can I just stop you, Nina? Can I just stop you, please? Can I just stop you? Yvonne, can you put yourself on remote, because we're getting an echo from you. Yeah, just put yourself on not on remote, on mute, please. No, she wasn't, because I had to blow her nose. So it definitely was you, Yvonne. Okay, you done it? Okay, lovely. Well, I heard you blow your nose, so you couldn't have been at the time. Sorry, but unless somebody else blew the nose that I didn't see. Okay, sorry, Nina, for that. I couldn't. It was echoing back at me, and I couldn't hear it properly. If you want to carry on now.
Thank you. I was just saying, in terms of restoring services, diagnostics is a pinch point for us, but we are working with the independent sector hospitals to use their capacity, and that's been a really excellent partnership, and that has enabled us to continue the level of service that we've been able to provide during phase 1 of the incident.
Are you happy that we're happy with the response, John?
Did I hear the answer to how much new phlebotomy increase we were going to get? Did I miss that?
You did miss it. No, you didn't miss it, Councillor Doddy. We didn't give you an answer. I don't have the answer to that.
Draw blood.
Yes. But yes, I agree. We will include that answer in our response around sort of testing, and so my apologies, I can't answer that now.
I just wanted to chuck in one last thing, that we talked a lot about homes, and we talked a lot about caring in the nursing homes in particular. And one of the biggest changes that I've seen over our primary care network and over the clinical commissioning groups in total is a real drive towards employing huge numbers of pharmacists, going into these homes, looking after every medication that every single person is on, bringing a level of safety that's probably never existed in the history of care homes. So just keep your eye out for that. That's a huge development, great safety development. Will keep a lot of people in nursing homes who previously through polypharmacy defaulted to hospital, and it's a great development through the primary care networks and the CCGs. So just wanted to update people on that. Thank you.
Brilliant. Lucy, could you just repeat the bit that you're going to come back on, because I missed it?
I've got no.
The question you didn't answer, though. What was the question you didn't answer?
How are we creating the additional phlebotomy capacity to do the additional to do the antibody testing?
Okay, thank you.
How are we getting on with
at
it?
the end, that's all. Antibody testing. Okay, lovely, thank you. And then I've got Councillor Martin then, and that's it, I think.
Yeah, thank you, Chair. Yeah, I've got a couple of questions really. How sure are you? How convinced are you that the system for testing patients that were released into nursing homes during the pandemic was robust enough? Because obviously we had a spike in nursing homes and people were still being transferred from the hospital trusts to nursing homes during the pandemic. I had a particularly bad case, you know, where I am in my division, and what was the level of support that was supposed to be given to the nursing homes, you know? And my other question is really about blister packs in Mansfield and Ashfield. A lot of pharmacists during this COVID pandemic have not been producing the blister packs, and so the care workers who are taking them, or they're being delivered to the patients around, you know, at home, have been particularly struggling during this pandemic because the blister packs have not been arriving. So I know that's not quite your remit, but it's in NHSCI, whatever it is, you know, and that surely was one of the main things that patients were used to receiving. And I've been reliably informed that this problem existed before COVID as well. So if there's a charge complication, then it needs to be ironed out, because blister packs are quite important for the well-being of the residents who are at home self-isolating, really, you know. And the other thing is as well, I'll rephrase my earlier question, because I don't think it's my place or anybody else's place to put the words into the mouths of experts, external experts, but you clearly are concerned about weekly testing. And the staff at hospitals are clearly concerned about it, because all these different outlets have set up mental health and well-being units. You've just said, you know, at Queen's you can go to a room and talk to people. So it clearly is an issue, and I'd just like you to confirm whether you think it is or not.
My response to that is the same as it was on the first question. I think you're putting people in a position where they might not want to answer. So it's up to you, Lucy, if you want to do that. You're on mute, Lucy.
I think I wouldn't want to give an opinion, and I can't answer with fact on that one. I think that's probably a question for the acute hospital chief executives. Clearly, testing. I mean, testing, tracking, and tracing of patients is a key, and staff is a key part of the pandemic response, and will need to continue to be. If, in answer to your question about when patients were initially discharged from care homes, do we think that we were properly testing? I think no. I mean, that was a part that we had some pretty rapid learning about that, and I think we have significantly improved the way that patients are discharged from care homes. So I don't know, Nina, have you got anything to add on that?
No, I think that is part of the learning about the relationship with care homes, and certainly it became a national focus, and locally we responded as quickly as we became aware of the problem.
Do you want to come back, Martin?
Yeah, just about the blister packs. Can we get a response on that, because it's quite an ongoing problem for patients, and it's happening now. And it's affecting a lot of patients across Mansfield and Ashfield. And if the pharmacies are going to charge for it, then we need to sort it out, don't we?
Yeah, so I will get you an answer. I certainly can't answer that question, and I can assure you that there's been no decision made in any commissioning authority that relates to money that would have made that happen. So I don't know whether it's a shortage of supplies. I don't know, but we will look into that.
But allegedly it was happening before COVID. It's quite an important issue, really, because obviously patients at home before the pandemic, and even more so during the pandemic, rely on the blister packs for their daily intake of medicine, and the dementia patients and all that.
Okay, lovely. Thank you very much for that. Do any members who have not spoken have any further comments, questions? Who? Oh, sorry, Kevin. You're next.
Thank you, Chair. It's just a quick one, actually. We've talked a lot about testing this morning. Just a question. Do we count how many tests we do per month in Nottinghamshire? And do we count the tests and not the people? Because counting the people is 100% we're sure what that means. But when you're counting tests, that's 2 tests per person, it gets a bit confusing. So if you could give us an update on that, that would be good. Thank you very much.
Yeah, and I think you're absolutely right, because single patients will have multiple tests. I think I can say with confidence that we count both, but we'll include that in our update on testing.
Thank you, Lucy. Martin Gately, do you have any questions, comments?
It's a question for yourself, really, Chair, and for the committee. I've noted various areas that members are interested in coming back in relation to this: mental health, remote consultation, the lessons learned, and infrastructure. I was just wondering, you presumably want those factored in over a period of time into the work programme. You don't want a sort of COVID-19 update every single meeting going forward. I'm just sort of asking you how you want it dealt with, really.
Anybody got any comments on that? All right, I was going to bring up that in my summary anyway, Martin, but I think from my point of view, any report that we get coming forward is when it's appropriate to do so. You can't really do a lessons learnt until you've sorted it out, really. So I'll just do the summary, and I think that might be a point of discussion that we have offline. So when's the appropriate time to bring it forward? Thanks ever so much, everybody, for your contributions there. I thought that was a really good debate on the COVID. So I'll just get you some of the things I've captured. So we need the follow-on information regarding testing, take-ups, lessons learnt paper, and when it would be appropriate for that to come forward, mental health impact of COVID, staff well-being through the COVID pandemic, additional information on antibodies, and the blister packs. Have I missed anything out? I don't think I have I? Okay, so are we all resolved that'll be all come part of the next of our work programme, and we'll fit it in when we feel it's the right time to do that, so that it'll give everybody the opportunity to get the report sorted. In terms of the mental health, I've also got to include the providers. So just so you know that, Lucy, that yes, that's down on that as well. I think that's very important, because obviously you commission them; they're the ones that actually provide that service. So thank you very much for your coming along today. Please pass on our thanks to the NHS and the staff for all the hard work they're doing. I think it was Liz that brought up, are we going to do a response to that? Absolutely, Liz. I think maybe a letter from me, if that's appropriate, if you think that's good enough, thanking our NHS and our GPs and everything for all the hard work that they've done during this pandemic. If you feel that that's not enough, please let me know, and we'll look into what we can actually do. Yeah.
Keith, before you close down, I've been waving like mad. Well, anyway,
sorry, Stuart. I didn't.
It's all right. It's all right. Just could to the list you add the influenza, because the vaccine is crucial to us. Without that, we're going to find ourselves into a bigger mess than we were already. Thank you.
Yeah, absolutely, Stuart. Sorry, I didn't see you. Your hand doesn't come up on the thing. But anyway, it doesn't matter. Yeah, I'm happy to have that added. So that's an hour will be part of the minutes anyway. So yeah, thank you, Lucy and Nina, for your answering all the questions in a really positive and fullness way. That's it as far as you're concerned, I think. Right, work programme. To reintroduce the item, please note dates and agenda items remain subject to review in light of the ongoing COVID-19 period. I now invite Martin Gately to comment in more detail. Martin Gately.
I don't know how much more detail I've got to add to that, Chair. Thank you very much. The work programme has been severely disrupted due to the cancelled meetings caused by the pandemic. And over the course of the next couple of weeks, I'll be rejigging that work programme. So reprioritising it really to make sure we've got everything we need to have all squared away and with dates set for the autumn and going forward beyond that. And that's it really. That's very much a work in progress at the moment.
Okay, does any members have any questions, comments on that? I've got Councillor Greaves first.
Thank you, Chair. It was just a quick one on Rampton Hospital. How they have coped with staff and patients through this pandemic. Would it be appropriate to have a word with those?
Do you want to comment on that, Martin?
Yes, I mean, yes, of course it would be. Councillor Greaves, yes. I'll have a word with them and we can put something in place. You wanting them to come back specifically, or just to get hold of a briefing for you to see if there's any concerns? Or
well, I think they don't need to bring them to the table. I think just a report of how they've been coping through the pandemic with staff and patients. I think.
Yeah, cool. Good to do that. Brilliant. Yeah.
Okay. If we find that there are concerns from what they give us, then we can always call them in, can't we? So, absolutely. Yeah. I've got Muriel next.
Thanks. It's just when to ask for the lessons learnt review. In a way, we don't know when this will end. It can go on for months and months. And I was struck today by how much NHS are already thinking ahead. And I know Melanie, for ourselves, is already has already looked at lessons learned and is beginning to plan ahead. So it's perhaps a kind of, if you could negotiate with her to have a review when she's gathering things together, rather than wait for some point in the distant future when, you know, all will be sorted. So, you know,
yeah.
it may be a kind of two-stage review. One, you know, in the next few weeks or months. So what's our learning so far? And then perhaps a round at one later on.
When's our next meeting, Marty? Is it September or October something? Is it? You're on mute. You're on mute.
And now I'm on mute and I'm calling up the document. It is the 29th of September, according to the version of the work programme I'm looking at, 29th.
Would that be an appropriate date to call them in for lessons learnt so far then, do we think? Or is that a bit soon? What do the committee feel?
Sounds a bit early to me, Chair, but I'm happy to be guided by the committee.
Yeah, a bit early. What's the one after that then?
It's November. We were talking, weren't we, about possibly having a special meeting in October to look at NRC consultation. So if we have an extra meeting, I guess we'd have to see what else is cropping up around that time and how much time NRC consultation is likely to take place on the agenda. So it would be either end of September, a special meeting, or 10th of November.
Right, I think the end of September is too close because I got lots of nods when I said that. You said that might be a bit too short. So let's look at it being a 2-item meeting in the special meeting.
Okay, got it.
Yeah, and if we work on that principle, then that should give them plenty of time to come up with some of the lessons learnt so far. And it will be a so far because I'm sure as we start to come out of the pandemic and they start to work towards recovery, that there'll be lessons learnt then, and then we can bring that up afterwards. Are we all happy with that? Okay, Councillor Martin.
Thank you, Chair. Yeah, I just wondering if we'd all be able to sign, all the members of the committee would be able to sign the letter to the NHS. And the other thing is, on the work programme, can we get the arrangements for PPE onto the work programme for council staff?
Yeah, I'm happy with that. I think to get all the signatures on, it's going to take, months, knowing how you councillors are unavailable. I've got you, Yvonne. How you councillors are unavailable most of the time. I think, I represent the committee, and I think it's appropriate for it to be me, unless you as the committee feel you all want to put your signature on. I'm not getting any nods, Councillor Martin. Sorry. It's a great idea if we was all meeting up. It'd be dead easy. We just come into the meeting, all sign it and get it off. I will make sure in the letter that it's very clear that it's from all of the committee. Yeah. So you will get the kudos for giving that support and praise. Is everybody happy with that? Apparently I've just got a whisper at COVID distance. There's a PPE council PPE report going to personnel committee tomorrow. Yeah, so if you're interested in the PPE for council staff, attend that meeting and you'll be able to find out in more detail. If you do that and you feel that it wasn't adequate or anything like that, get in touch with us and we'll have a discussion on whether it needs to come to us or not. Are you happy with that? Yeah, Councillor Martin? I can't hear you, sorry. Are you happy with that?
I just think it'd be prudent to scrutinise it.
Well, let's see what the report says tomorrow. Yeah, and if we feel that it needs to be scrutinised, we can scrutinise it. If it says that everybody's had all the PPE they need, then there's no need to scrutinise it. If it says there's been issues, then we can bring it in and look at where those issues are. What do we feel as a committee? Do you want it to come anyway, or do you think we should see out what comes out tomorrow? See what comes out tomorrow?
What you've got first, and then make a decision.
Absolutely. Is that's what I'm getting, Councillor Martin, as a general feeling? Yeah. Okay, so if I get, I'm sure there'll be other members of this committee who will be watching that report tomorrow, and then if I get the right amount of feedback saying you want it here, not trying to hide anything, let's get it here, absolutely. But if there's nothing to bring here, I don't want to be filling the item with something that actually something more important could go to. Any other questions in terms of the work programme? Oh, sorry, Yvonne. Yvonne, did you want to speak? I do apologise, darling.
No apology necessary, Chairman. We were assured in the briefing for the Personnel Committee meeting tomorrow that Nottinghamshire County Council have a stable supply of PPE and everything that we could possibly need. We have a stable supply in place.
Brilliant. And I'm sure that the members of that committee we'll challenge that to make sure that that is absolutely right. So yeah, I'm confident that the personnel committee will do their duty on that. But as I say, if we feel that actually we're not satisfied with what the answers have been, then absolutely I'm more than happy to be brought to us. But there needs to be a reason. Okay.
Okay.
That concludes the business of the committee. Our next scheduled meeting is on the 29th of September. Please stay safe, keep your distance, don't drink too much, don't fall over, and don't need a GP. Thank you very much, everybody. Thank you.
Thank you, Chairman.
Thank you, Chairman.